So you can, I guess, start the live stream, the spotlight, and all that good stuff. Good morning, good afternoon, and evening to colleagues from around the world. My name is Lisa Hilme. I'm a nurse and executive director of Core Group, a consortium of over 15,000 global health practitioners from around the world, prioritizing women, children, and adolescents. Welcome to our second event in a series of 3 on prioritizing actions for epidemic and pandemic preparedness, science-based approaches for prioritizing capabilities for preventing, detecting, and responding to infectious disease epidemics and pandemics at the country and regional levels. I will begin by reminding everyone the statements, recommendations, and opinions expressed here today are those of individual presenters and participants and are not necessarily endorsed or verified by the national academies. Discussion should not be construed as reflecting any group consensus. The planning committee is the group responsible for developing the agenda of the symposium, and bios of the planning committee are listed in the speaker and attendee list on the webpage. I would like to first start by thanking the committee members, and I believe we have a slide with all of their names, as well as our incredible participants at the national academies that have been leading us through the past couple months. Thank you so much. Where we have Dr. Kavita Berger, Dr. Julie Pavlin, Dr. Polly Joseph, Dr. Sabina Vadnes, Nikki Kwong, Nam Vu, and our incredible committee roster. As I mentioned, you can read all of their illustrious bios in the speaker bio. So this is the second in a series of 3 that's action-oriented and forward-facing. The first symposium session on May 4th examined and highlighted critical needs, challenges, and gaps in the international and national governance and financing for developing and maintaining those critical capabilities needed to prevent, detect, and respond to future epidemics. We discussed the political and the economic context for sustainable international epidemic preparedness, as well as the governance and finance, including regional and country efforts and building trust. Some of the key takeaways included that we need to move our efforts forward with a One Health approach, investing in pathogen surveillance and lab capabilities, as well as quality data systems. Equity is key in access, funding, decision-making, and power to translate policy into practice. We also discussed how building trust in preparedness and response efforts is key at all levels, from the community, national, regional, and global, and involves political will and accountability. And there is also a need to take stock of country and regional JEE and IHR efforts, as well as other tools that are being used to determine any adaptability training that may be needed. And there was a lot more discussed, and you can read more about this in the report that will be released after this series, as well as on the National Academy's website, where many of the recordings will be. Today, we have 2 sets of concurrent discussions. The first group focuses on 3 areas: situational awareness, trust, transparency, and risk communication, and governance, finance, and accountability. The goals of these discussions are to review the success and failures for each area, use and relevance of existing assessment tools, both at the regional and national levels, and the critical gaps in areas that need action. It is my pleasure to introduce the moderators of these first 2 sessions. All of the moderators today are also members of the planning committee, so once again, thank you. Our first action group is situational awareness in the context of health and disease. And this session will also be live streamed at the National Academy's audience, website and audience. It is going to be moderated by Dr. Larry Brilliant. Larry is a physician and epidemiologist and currently the CEO of Pan Defense Advisory. He's a senior counselor at the Skoll Foundation and an advisor to the World Economic Forum. The second topic is building trust, transparency, and risk communication capabilities, and will be moderated by Dr. Richard Garfield. Richard is a nurse and epidemiologist and currently the acting team lead of the Global Health Security Team in the Global Health Center at the U.S. Centers for Disease Control and Prevention. The third topic, strengthening global health security through strong country-level infrastructure for effective governance, finance, and accountability. And it will be moderated by Julie Wall, who is a program management advisor within the Prevent Epidemics unit at Resolve to Save Lives. She will be joined by Gisela Scaglia, who is a former member of parliament in Argentina and currently works in social development promoting global health projects. Following these concurrent sessions, we will have a 10-minute break and then reconvene for another session, which includes two topics. The first of those is global health security, capacity and functional assessments. And the second topic is countries and organizational experience in preparedness and response planning. As I mentioned, during each session, one of the topics will be live streamed for the webinar audience. For those watching the webinar, please use the Slido link to access where you can enter questions for the speakers. We want this to be a very interactive, even though we're Zoom, a session. So please make sure that we get your questions so we can feed them back up to the presenters. Also note that the recordings of all sessions will be available afterwards on the National Academy website. At the end of the second round of concurrent sessions at about 11 a.m. Eastern Standard Time, we will be rejoining everyone together to discuss some of the highlights from all of these sessions. And right now, we are going to, for all of those that are viewing the webcast, we're going to also have a Jamboard ready, and these links are going to be put into the chat box for you. And so that you can add your comments, you can add your questions, and we will be capturing everything real time, which will help us inform reporting and also next steps. So at this time, I turn it over to our National Academies team to break us up into the Zoom rooms. And I wish you all a very exciting and interactive dialogue.
Brilliant. It's my pleasure to be the moderator on this panel, which is called Situational Awareness. Just a word about why we're calling it situational awareness. I think all of us know how important early detection of novel viruses has shown itself to be during this pandemic. But the key to really understanding a new disease, an old disease that we're familiar with that reoccurs, is to understand where it is, where it's going throughout the entire course of that disease, including the assessment of the program and the interventions. So we decided to use this term situational awareness in the context of health and disease. We have about an hour and 20 minutes, which is a good long period of time, but never enough, to discuss all the issues relating to disease surveillance and situational awareness. I want to focus on one thing which we'll come back to at the very end, which is after the discussion and the panelists and the questions from the audience, we're going to go back to the question of what should we do different? What's the most important thing that we've learned from this that leads us to action? That will be the final question for this panel. So let's get started. The discussants in this panel are Mark Smolinski from Ending Pandemics, Patiput Keng Susampao, who he has asked me to call him Kang, and Chane Su, who's the co-founder of Kaohsiung. I'll be introducing each one of them a little bit more. The structure is going to be that Mark Smolinski is going to give us an overview of situational awareness and disease surveillance for about 10 or 12 minutes, and that Chane and Kang will talk about some incredibly interesting innovations and breakthroughs that they've created in their countries. So the goal of this entire panel is to reset our expectations at a higher level of what we can do and what should be expected for us to be able to do to both keep public health and the general public aware of changes in disease risks as early as possible by combining many current surveillance systems with new sources of disease data to form almost real-time awareness of the constantly changing pattern of disease risks. And we're going to start with Mark. Mark, as I introduce you, and Mark has a slide set, I want everybody to know that 20 years ago, Mark Smolinski led a National Academy meeting of 18 experts on the topic of microbial threats to human disease, including detection and response and assessment. Mark, that was 20 years ago. So now we get the benefit of all that you've done at the National Academy, then at Nuclear Threats Initiative, at Google, at School Global Threats, and now at Ending Pandemics. Mark Smolinski.
Well, thank you very much, and greetings everyone, and a very good early morning. Welcome, good afternoon, as well as very good late evening for those joining on the other side of the world. No matter where you are beaming in from across the globe, our conversation this morning is a topic that brings challenges as well as opportunities to all of us: situational awareness in the context of health and diseases. Terminology does matter, and I understand the shift, especially as articulated by Larry, from using surveillance to what many perceive as a less loaded term of situational awareness. For me personally, I still prefer surveillance, as we need to be more than just aware of the situation. We need to act. So thank you for this opportunity to share my viewpoint on disease surveillance and where I see the field of global health changing quickly, but certainly not quick enough. So allow me to share a few slides. Okay, the problem with sharing slides is I lose all of you, but I'm assuming that we're good to go. As we're now all no doubt doing for numerous inquiries, I began preparing for this session by typing into OpenAI's ChatGPT the query, "What is disease surveillance?" And the results warmed my heart as it covered many of the key elements of surveillance essential for preventing and responding to disease threats, and is in line with my training as a medical epidemiologist. I've highlighted two of the most important key phrases here: the systematic and ongoing collection, analysis, interpretation, and dissemination of data, and also what I feel to probably be the most important element of surveillance, which is to inform public actions and interventions. So as long as situational awareness calls for this action to be taken on the information gathered, then I'm happy to embrace this term as well. So regardless of what we call it, detecting and responding to disease threats is challenging for a variety of reasons, and we certainly don't have time to delve into each of them. But just to highlight a few, many disease surveillance systems are too slow, they're too expensive, or they lack the adequate financial resources. They're not equitable or representative of the population at large. We have poor coordination, weak laboratory capacity, poor communication systems, erratic feedback, and inadequate training of health workers. And they focus on response rather than prediction and prevention. And finally, the effectiveness of systems is often evaluated based on the wrong information. So these are only a small fraction of the challenges that we face in disease surveillance. But if you have one takeaway to remember, it would be that speed matters. So every microbial threat is different, but in all cases, the speed of detection and the transparency in the identification of the emerging threat are essential to stop the spread of any outbreak. So we're often asked, how fast is fast enough? Well, that depends on the characteristic of the microbe, along with a myriad of other factors, not the least of which are human behavior and political will. So perhaps the greatest challenge we face as a global community is the transition from our human-centric approach to disease surveillance to one that is truly One Health. So while many have embraced the concept of One Health, putting it into practice is a whole nother issue. So unless we truly implement One Health, we will continue to detect and respond to one outbreak after another, rather than getting to where we have the capability to be as a global community, predicting and preventing disease threats. So let me illustrate this point. Take this typical epi curve that could represent any of a number of diseases. We have disease reporting requirements, but they're often too late in the game to really flatten this curve. And I know flatten the curve has taken on a whole new meaning in COVID, but in here we mean reducing the area of the curve, which represents less people impacted by the disease. And we relied on astute clinicians to sound the alarm on unusual presentations or clusters of illness, and this has helped us find outbreaks faster in many cases. I was on the team that investigated hantavirus back in the early 90s, and it was the conversation among healthcare providers in the doctor's lounge talking about the number of young people who were presenting with a respiratory illness and many succumbing to death within 24 to 48 hours that really was the trigger for identifying this unusual cluster and identifying that this outbreak was something serious. And later on, we discovered that it was due to a hantavirus. And then we've established sentinel networks, both nationally and globally, for diseases like influenza and antimicrobial resistance that have helped us reduce the impact of emerging conditions such as these. But perhaps one of the greatest impacts on finding outbreaks faster has been the introduction of digital disease detection, or the automated scraping of media reports and machine learning efforts that have definitely led to earlier detection of potential health threats. In fact, it was this advance in disease detection that impacted the revised international health regulations, which now allow WHO to act on such informal sources of information rather than previously only acting on official reports from a given country. And today, WHO operates the EIOS initiative, or the Epidemic Intelligence from Open Sources, that automatically reviews over 20,000 electronic sources of information on a continually basis to detect any potential One Health threat. But we haven't stopped there. Further progress in finding outbreaks faster is being realized by the significant expansion of participatory surveillance, or the direct engagement of communities to be the eyes and ears on the health of themselves, their families, their animals, and the environment. So yes, we are moving from our human-centric approach to fully embracing surveillance in animals. And when we combine this with other factors in the social and physical environment, we can really begin to realize the value of One Health. So with 3 out of 4 pathogens with epidemic or pandemic potential directly arising from animals and spreading to humans, an integrated approach to disease surveillance across species and diverse ecosystems is the future of global health. This map identifies some of the most efficient, cost-effective, and integrated surveillance systems today across the globe. All of them are bidirectional in receiving and transmitting data for action by engaging directly with the target population. Many of these systems have incorporated wearable technologies, genomic sequencing, and even sewage sampling from humans and animals to find the earliest signs of an emerging infectious disease. Participatory surveillance is how we actualize One Health and we improve equity in disease surveillance. And you're going to hear from two such systems on this panel, the PAWDD system in Thailand from Kang and the 115 hotline in Cambodia from Chan-A. And I'll leave it to them to share the highlights of their One Health systems. But as we move towards more automated disease detection and directly engaging the public, we also have the challenge of incorporating these innovations into the disease surveillance infrastructure within a given country. In addition, we need to share this data with all the sectors that make up One Health. So don't worry about the details of this slide, but I'm just sharing this system in Tanzania, which exemplifies where we are heading in the future. So what this slide illustrates is on the left-hand side, all three ministries, human, animal, and environment, are working together to share the same information on a One Health dashboard that brings together data from crowdsourcing in the community, from hotlines, from these media scanning, and on the far right, you can see they even connect to the global systems like GFIN and EIOS. But the important point to take home is here in Tanzania and in several other countries, all of this data now is being shared in real time equally with all of the sectors who are responsible for One Health. And it's really changing the dynamics of how they're reacting to disease threats in the community, because now they truly are in it together. And data is a very powerful leveling field when it comes to looking at infectious diseases. So countries can't operate in isolation, however. They have to be able to share this information directly with their neighbors in trust-based partnerships in these hotspots for emerging infectious diseases. And one example of a regional collaboration is CORDS, or Connecting Organizations for Regional Disease Surveillance. And CORDS is 28 countries and 6 regional networks in these hotspots that not only work across borders within their respective region, but they work together to share learnings, promote One Health, and advance innovative models in disease surveillance. And there are numerous other examples of regional collaborations, but the important take-home point is this kind of collaboration across borders is essential for pandemic preparedness. And finally, a word on measuring progress. So numerous systems have emerged over time, including the Joint External Evaluations, the Global Health Security Index, and many others that are time-consuming, expensive, and often deriving results that do not match the reality when put to the test of responding to a pandemic. Perhaps we have made this all too complicated. What about a simple set of metrics that every country can embed within their programs, within their standard operating procedures, and use during their after-action reports to monitor their own performance and set goals and objectives for improving these metrics over time, not necessarily to compare themselves with their neighbors, but as their own metrics to drive continual improvement. And some of these are shown in the slide here that include time to detection, time to verification, and time to intervention, but also laboratory confirmation, public communication, and really just a small handful of metrics that allow a country to embed these within their systems and really monitor progress. So in conclusion, I've covered 5 critical components of disease surveillance: deploying a One Health approach, engaging directly with the public, expanding epidemic intelligence, collaborating with neighboring countries, and measuring progress. And I believe that optimal disease surveillance can be achieved in all countries through the application of these 5 critical components of systems change, using science, technology, and innovative practices that are adapted to the realities of the populace, to the geography that they're being implemented in, and to the infrastructure capabilities in these planetary hotspots, so that we can expedite the early detection of any emerging threat. I thank you very much for your time, and I turn it back over to Larry.
Mark, that was terrific. Thank you very much. I want to just put that in context, and it's a context that all of us know so well. With increasing human population, with humans and animals sharing territory, humans eating more and more animals, wild and domesticated, the wet markets, as we've seen, that cutting down of rainforests and changing the territory that animals live in, spillover is inevitable. Outbreaks are inevitable. By some estimate, there's 300,000 viruses in animals, potentially zoonotic diseases, that have not been categorized or even identified. If spillover is inevitable, outbreaks are inevitable. But there's nothing inevitable about epidemics. There's nothing inevitable about pandemics. They're really optional. And if we want to do something to cut the chain between spillover and outbreaks into pandemics, we need early disease surveillance. And as Mark showed in his graph, we need to move the epidemic curve 2 steps to the left, closer and closer to where the first outbreak begins. And there is no better example of that I know of than what Thailand has done. So it's a pleasure for me to introduce Patipat. And Patipat, who we're going to call Kang, Kang has been part of a group in Thailand which has just, in the past weeks, won the Trinity Challenge. That's over 1 million pounds. They won the grand prize for the most innovative and I think the most important detection system that has arisen, that is appropriate for countries that don't have the resources that maybe the United States has. And it's so important that the name POD-DD, and I'll ask Kang to explain more about what that means, but it's sort of a dual purpose name. It's an acronym, but it's also a Thai word that conveys the importance of communities acting together. And Kang has been an engineer, a techie, an applications creator at Open Dream, a company and organization in Bangkok. And he has been instrumental in creating many of the applications that has made Thailand such a leader in disease surveillance. So Kang, I turn it over to you and welcome to the National Academy meeting.
Thank you very much, Larry. Sawadee krap, and good evening, everyone from Thailand. My name is Kang, and I'm today, like I work for the company named Open Dream. We are a technology social enterprise based in Bangkok. But today I'm going to talk about the project that's called PODD. PODD stands for Participatory One Health Disease Surveillance in Thailand. That we have been working with Chiang Mai University in the northern part of Thailand since 2014. PODD, as Rally mentioned, PODD itself is an acronym that has the pun to the northern Thai words, means look carefully. So we want to at least, and at first, back to in 2014, we want at least start with a good name, and then we hope that the good outcome will follow. So the PODD itself is the participatory approach, and we adopt One Health approach to detect the animal outbreak, especially in the backyard farming sector. So PODD consists of 3 elements. One is it's the surveillance system and approach. That means that we help the local government set up their own surveillance network in the local community, and it's an application. So basically, it's just like a simple application that the ODs, no, the elders can use without any obstacle, and it's also the early warning and rapid response system. So we hopefully to like accelerate the time to detect and time to respond in the community level. And traditionally, all the disease surveillance in Thailand is responsible by the government officers, but sometimes the small outbreak in the rural community, especially in the backyard farming, is not get enough attention from the local from the government. So we want to turn the table and empower the local community to be able to respond on their own. And the policy itself, we actually rely on most of the existing collaboration, but we want to strengthen the data pipeline and collaboration between community and government agencies, and also create a single truth platform so everyone can work on the same data and the same report. So it started from the top level. So whenever incident happen, the villagers can start reporting, or even the villager go to our volunteers, which is a trained volunteer, and majority of them were not the health volunteers. Some of them were the housewives, some of them were the mechanists. So if everyone can be the reporter, and the villagers who become the reporter can send the report to the system, and we have one health expert and predefined algorithms to help verify the incoming report. And if it's fell into the predefined criteria, we can send notification to various stakeholders in the community, for example, public health officer, DRD officer, or even local government leaders, and they can start working together. We send notification into multiple channels, from short message services, SMS, or to the similar application like WhatsApp, so everyone can have the same information at the same time. And we have a dashboard that everyone can work all together and update the situation, what's going on, what resources needed, and they will use that space to collaborate and stop the outbreak. So since 2014, we have been working mainly in Chiang Mai, but we are expanding into other provinces across the countries. Currently, we have about 20,000 volunteers on the system, and we have been implementing into 31 provinces out of 77 provinces in Thailand. So as Mark have mentioned, the metrics that we are trying to measure the success of PODD itself is that the first is time to detect. The Chiang Mai University did this research last year, and we found that the majority of them, around 45% of the community, can detect the outbreak within 1 to 3 days, and the rest of them can be detected within 2 weeks, which is if you think about previously the backyard outbreak, which normally was not be able to record because it's probably too far away or too rural, so the government officer doesn't know what's going on those communities. So we can speed up the time to detect into the fastest was 1 to 3 days. And for the time to respond, we found that the majority, also the majority of the villages at the community, more than 54.5% of them can implement the control measure within half a day, and the rest of them can start control measure within a day, and also some of them can do within 2 days. So we can speed from time to we can speed up the implementation control to half a day at the fastest. And we look further into like how long does it take for those communities to bring the outbreak under control. So from we use from the first case to the last case that has been detected, and we found that 90% of communities can bring the outbreak under control within 3 to 4 weeks. So this is we hopefully that if the next pandemic, for example, COVID-30, is happening in rural community in the under PODD's watch, we are quite confident that we can bring it down and under 4 weeks, and there would be no COVID-31. So the PODD itself, we looking into the incentive and the data and create the early warning system. So one of the incentives were we encourage the volunteers and the community members that they can protect the family and the community, and also protect the livelihood and prevent the economy loss. And also one of it eventually will be prevent and stop the outbreak in the community and the next outbreak. So the 3 pillars of PODD is we rely on local volunteers. So we need to have local volunteers who from local who've been trusted in the local level. We need to have a governance structure so we can tell the stakeholders what to do when something happens and where to go. So they can have the same standard operation procedure and work on the same thing. And also we have technology to bridge those gaps and make them make a collaborative platform so people can work together. And of course, if we have this, we can reduce the cost and especially the economic loss and eventually will increase the health outcomes of the community. But we want to detect the emergence of the novel diseases even faster. So we are looking into the way to detect the other 6 now from using metagenomics and using the wastewater surveillance. So we want to collect, we want to look into the wastewater in the community and use metagenomics to identify any pathogen and diseases that could happen in the community and protect the spillover. So we hopefully assemble the team of researchers to test this out in the community and hopefully we can start it this around the end of this year. So that's what we are working in Thailand right now. Thank you very much.
King, thank you very much. We talk about the time to detect matrix and metric. I think you can see from the effort that King has put into trying to categorize diseases by how quickly they're detected and responded to, how important that is. In real life, King, I have been so impressed with 2 examples of how Thailand's disease surveillance system has worked so well. One, of course, was the 2 exportations of MERS from Saudi Arabia, one into South Korea, one into Thailand. And the sad story of what happened in South Korea was the number of cases and the number of deaths was so high. But in Thailand, that wasn't the case. Thailand was able to find the first importation of MERS and basically stop the disease at that point. And I attribute that to the work that you and your colleagues have done in Thailand. What does all this cost and who pays for it, Ken? And think about countries who'll be listening to this, who'll be saying, I want a system like you. How much does it cost and who pays for it?
Yeah, we thank you, Riley, for the question. The initial investment came from a global threat fund, and we use that to set up and develop the system and also all the experiment in the community for 2 years. And after that, the local initially we support the local community on everything because this idea was very new, and back in 2014, not everyone has a smartphone. So we use part of that support to buy the smartphone, buy the data for every community member. But that's back in 2014. After 2016, most of the community members and like leaders say that we should stop supporting them because otherwise it's not going to be sustainable in the long term. And currently, all the local government are paying or like at least supporting the train of the network, train of the trainers, and also Chiang Mai University is supporting on the running the system, and normally the cost that incur to the local government budget also part of the setting up and running and keep continuing for the work in those communities. So it's not very much, but for some community it needs to be a think through. So that's why we started with like free system for everyone, and at the end they start paying it when they see the benefit, and they can find the dimes that laying around inside their local community, and start supporting that one.
Thank you so much, King. And now we're going to move just a little bit to the east, and we're going to move to Cambodia. And I'm going to have the pleasure of introducing Chane Su Lan. Chane is a technologist. She's a leader and an expert in information technology for development. She previously ran the Instead Laboratory in Phnom Penh and has been a leader in appropriate technology for early detection. She's recently launched Khao Sang in Cambodia to create even more innovative solutions in communities to improve public health. And it's a pleasure for me, Chane, to see you after a long time and welcome you to the National Academies.
Thank you, Larry. Let me just share my screen here. Okay. Yeah. Okay, I can see my screen. Okay. Yeah. So it's a pleasure to be here to share about the case in Cambodia with everyone here. So my name is Chane, as Larry introduced, and I'm a co-founder of Khao Sang. A non-profit, it's a social enterprise that graduated from a non-profit Instead iLab Southeast Asia. So we were a social enterprise that working on the technology for the addressing the public health or the social aspect in the community. So I'm gonna fast forward to maybe one of the turning point perhaps in my career, also in the organization that I been working with the team for the past more than 10 years, is in the year 2013, which when we started, we organized the Epidemic in Phnom Penh. Is the event that brought together the technologies and the public health specialists in the country and in the region to look into the what would be the next innovative solution to address the public health gap. So Cambodia was honored to host the first Epidemic in the country, this with the support from the Scope Global Threat Fund. And coming out from that was one of the idea is about the hotline. How do we actually engage, with the public, getting the public participated in the identify the disease signal. So that would come to the interest of the Ministry of Health Cambodia, and right after the Epidemic, the ministry really want to make that moving forward, and that where we work with the Ministry of Health and the Scope Global Threat Fund support, and takes from the idea from the Epidemic to prototype and testing at a small scale. So basically, the idea of the 115 hotline is because of Cambodia is a 16 million populations, and we're talking about there's a gaps also in the knowledge and access to technologies and so on. Then here we have to go to what would be the technologies that can be accessible by most people. So we designed the voice-based technology, based on voice call, not mobile phone voice call, allowing public to call and reporting. And when it call in, it's going to be going to that database system and capturing all the details, information, and so on. And another approach is also using the same mechanism of the 115 technology to improve the reporting from the health worker in the community. So two approach of it. And that's born the 115 hotline. And in 2016, In 2016, we launched the hotline with the Ministry of Health, and the campaign was done like a nationwide. Training was done to health workers nationwide, all the provinces, and the reporting startings. People started to report, and we can see like here. In 2017, that was like the aha moment for everyone, because that was the ideas of like getting the public to participate and to call to report. And in 2017, the first call from the farmer that led to the investigation and found out it's a H5N1 outbreak confirmed case in the country. And that identification of the case is not from the official reporting. This is directly from the farmer. So it was really a moment for all of us that we remember that. So this is something that we must say that also like Cambodia has something preparedness in hand before the COVID come in. So the hotline has been run since 2016. The public know about it. And so when the COVID hits, ministry has something in hand. So when the COVID starts, then the ministries like adapt and using the hotline immediately for the purpose of the COVID. When the start of the COVID, the test kit was not enough for the country. So and also people were panicked. So the line was used to provide public the information, the official information about what's going on in the country, getting the public to be less panic and knowing that this is the official reporting of the ministry. And it's used also to screen the eligibility for the test because there are not enough test kits. So the ministry, the public need to call in, and then they will go through the screening. Then those who are actually eligible will be direct to the testing. So that's really reduce the contact facing between like people, and also get the test kit sufficient to in applying. And we can see in here in this chart is the data from the hotline. During the COVID, you can see like the day that it can reach to about nearly, it's about like 18,000 calls in a single day for, in the country. And the red line is the confirmed, the daily cases of COVID in the country. Just so we can see how the public engaging is above the red line. It's very engaging during the COVID. And the call during the COVID itself, one thing that we also do is to make the hotline for the purpose of the contact tracing. So there is not enough staff to carry out the contact tracing. So we modifying another function of the hotline to send the auto call of the contact tracing to the confirmed case. So we said like 1.2 million call or to the contact, and only 1.3% of that call that has the confirmed symptom that that require human to follow up call. So it saves like more than 90%. It's really a massive saving of the human resources during the COVID for responding. So in short, the hotline has receiving over 2.3 million public call reporting, and from the official reporting from health center, like 340,000 report. 1.2 million of the contact tracing has been called sending out during COVID. And one of the very exciting thing is that the hotline is achieved with sustainability. We can say that because no longer funding from donors. It's been used by the ministry, run by the ministry, owned and operated by the ministry itself, and to the core function of the reporting of the Ministry of Health itself. Move on. I want to share quickly a bit, maybe extending, because that is the next next thing that we work also between human and animal health, because they're relevant to the situational awareness in here topic is the human and animal health monitoring, where the human and animal health, the Ministry of Health and the Ministry of Agriculture work together in a joint effort that using the same system to monitoring the event-based surveillance in the country, using the milestone and metric to track the event. And it is the first time for Cambodia. The project is supported by the ending pandemic. And it's the first time for Cambodia that human and animal health have the data sharing in the real system data sharing in a way. And this one is automatically when the case of the reporting from the province and match the case that agree to share, it will automatically share. It doesn't need another human to approve. So this is one approve, agree, and share the data between human and animal health on the key of the infectious disease in here. So yeah, so it's about like so this ran in year 2020, which is launched pilot, and we have about 297 outbreak event has been actually monitored and verified on the KNMS at the moment. And of course, like with our support, also another package is using verification fund to help the sub-national level to be able to go to verify the disease case faster also in the community. Oops. Yeah. So one lesson learned is in here is that for us is our work is starting from the beginning, always partnering with the government, because to have the change for the long lasting, that's our aim. Like 115, we want to ensure the sustainability. And also collaborating with the development partner to ensure that we synchronize our effort in supporting the government. So, and the next step, we actually now aim to work more, continuing as a momentum from our work is to extend to the One Health, where we're gonna bring like the environmental health partners to the tables and continuing the effort from where we are. Thank you so much.
Oh, Chane, thank you so much. I don't know about the rest of you listening, but those numbers are astonishing. Before I ask Chane a couple of questions, we're entering now into the discussion phase, and we have about 20-25 minutes. I hope everybody will think of questions to ask. And let me tell you several ways that you can ask these questions. First, of course, you can raise your virtual hand using the button for actions on your Zoom screen. But you can also drop your comments into the chat, just if you're in the Zoom room, or you can add comments to the Slido and or Jamboard if that's the method that you're using. So you've got many ways of asking questions. There's no excuse to not participate. We're talking about participatory surveillance, but we're also talking about a participatory panel. Either the Jamboard, Slido, put your questions into chat, or raise your virtual hand. So Chane, and I think the reason that in preparing for this panel, we've chosen two neighbors, one in Cambodia and one in Thailand, is because the economic development status of those two countries is so different. The penetration of smartphones in Thailand is very high. In Cambodia, it's not very high. So what the people in Thailand have created is a digital disease surveillance network, participatory surveillance, One Health, but it's digital. What you have done, Chane, in Cambodia is to create almost an analog system where anyone who even has a rotary phone or has a mobile phone, but is not a super advanced, expensive phone, can participate. And I want everybody listening who's in another country and is trying to figure out how they can get the kind of situational awareness and early detection that both of your countries have, is that for every country, at whatever the economic development level, there are systems that can be used. And as I think all of us know, the level of wealth and development of a country in the history of COVID, it's almost inversely related to how wealthy that country was. So what would you say that it costs, if you could put a number on how much the system costs to run each year or from beginning?
Thank you, Larry. So you point out a very important point, because when we start in the launch in 2016, it was like Cambodia smartphone penetration is very low. And that's one way we want to have like a solution that can be participated by public for almost like for all everyone that can access to basic phones. So Talk about the cost. It's from the start of in 2014 until we hand off to the government in year 2021. So that's about 1.2 million. That's been from throughout those periods. But we're not talking about yet about that. Actually, the call it's a toll-free line call. The public doesn't pay anything for the call, and the project also doesn't pay for the call. This is because of the government, it's partnership, and that's where the Ministry of Telecommunication come in and then taking part in contributing and enabling the toll-free hotline to work. And then now it's running by the ministries itself. It's all system up runnings, and we're partners also. So on other initiatives to continue to support the ministry. Yeah.
So is it fair to say that the system had a startup cost of single-digit millions of dollars, and now it is self-sustaining?
Yes.
I want everybody to hear that and to understand that when we talk about appropriate technology, or we talked about it in the 60s and the 70s and the 80s, so much of what makes technology appropriate is affordability. And being able to establish a national disease detection, early warning surveillance system for single-digit millions, and Johnny said 1.2 million, and then to have it self-sustaining is a key to making this idea of early detection available worldwide. Because the truth is, if it doesn't work in every country, it doesn't work. Emily, you have a question.
Yes, I have two, actually. I'm Emily Ricotta. I am Chief of the Epidemiology and Data Management Unit at the U.S. National Institute of Allergy and Infectious Diseases. Really interesting talk, both Janae and Kang. And so my first question is for both of you. How do you educate, or Thailand and Cambodia as a whole, how are the communities educated on the signs and symptoms and things to look out for so that it increases the appropriate reporting of diseases that you want to be tracking and decreases false negative calls? My second question relates to this is, how do these innovations, and Mark mentioned it a little in his introductory talk, but how do these innovations get brought up to the international community? How do we recognize them? How do we start recognizing them as helpful, valid, and good systems to incorporate in disease surveillance networks? And then how are these incorporated into evaluations at the national level, such as the JEEs or the GHSI, to make sure that these things are recognized as valid and important ways to collect this sort of surveillance data, and then countries are recognized for that in their national evaluations. So first question about, how do we inform at the community level? How are we making sure that data is captured well? And then how are we recognizing this on a national and international scale? Thank you.
Well, yeah, I'll answer your second question. That's what we're doing today. That's the reason why we wanted to showcase these two exemplary disease surveillance systems: low cost, country appropriate, and extraordinarily good. On the question of how do you let people know the system exists, encourage their participation, and what lessons for other countries, Chane, could you take that question first?
Yeah, thank you, Larry. When we launched the hotline in 2016, it was like the attention was very, from the beginning, it's about the campaign. So not only train and we make the campaign broadly to nationwide, and also we have the symposium in the simple way, also like the poster at every health center. There's a poster about the 115 hotline, and it's this simple. They don't have to be trained. Something just say, if you have anything suspicious in your community, anything that abnormal, suspicious, just call to this line, and that's it. But once they call in, basically, it's not just reporting. They're going to hear also new latent disease in the country as well on infectious disease that the government wanted to inform the public. Thanks.
And Kang, what about for Thailand?
Yeah, for Thailand, we are working in the community level, so we rely on the community for the local community to communicate with the people in the community. So for There are two parts. One is how to train the volunteers. So we did minimum training, about like 1 or 1.5 hour training for each volunteers, and we just tell them what to observe. We don't need them to be an expert. Just like, for example, if they found drooling animals, or if they found the animals that walk abnormally, those could be the sign of symptoms, and we ask our volunteer to capture those observable symptoms and send to the system. Doing that still don't prevent the fault report, but we don't encourage people to do fault report, but we accept that as the sometime, from our experiences, during the New Year Eve, some of our volunteers there get drunk, like Thai people get drunk on New Year's Eve, right? So they send some kind of like poem or like a lonely report, which is fine, because like at the end they're still thinking about our system and like send something to us. So and also we encourage them to do a zero report. So even though there is nothing happening in the community level, we ask them to send a zero report on every 1st and 16th of each month, because of it's a lotto day. So Thai people are crazy about the lotto. So like on the 1st and 16th, if there is nothing happen, just send like I'm okay, like
King,
a
I
zero
think,
report to the system.
and I think also for both of these systems, what makes community participation durable and sustainable is that people who have communicated and participated, they've seen action. Emily, they've seen action. They've seen when they report into the 115 system, where they participate in Pod DD, they report something and then the government responds, or the community responds, or their neighbors respond. That's what does it. You can do all the publicity that you want in the beginning to enlist people, but to get people to participate, it has to be meaningful for them. And both of these systems have done that. We have a question from Mohammed Afolabi. Mohammed?
Thank you very much, Larry, for your excellent moderation. Sorry, my internet went off momentarily. I'm happy to be back. So I want to commend the 3 speakers for the great presentation. My first question goes to Mark. So I was really, really impressed to see that the nice data and the illustration you show was actually from LMIC, specifically in Tanzania. I just want to clarify whether this was before the current government, because I understand during COVID pandemic, the government there was not amenable to many of the issues surrounding COVID testing, contact tracing. So, and that brings to the front burner the importance of the political will in entrenching this particular One Health approach and situational analysis or awareness. So I want to see when this particular system was put in place, because it's an excellent model that should be considered for adoption in Africa and other LMIC. Then secondly, I also want to thank Keng for sharing that PODD in Thailand. Is that correct? But I'm wondering why it's only focusing on animals, because it says One Earth, I think it should transcend between a man or human being and animal. And what does the role of cultural practices, what role does it play? Because in Africa, where I come from, it's not, they don't see animal getting sick and you go and report to a government. So they're always happy. There's a kind of a slang in the local parlance that if animal gets sick, you just go and prepare your pot of soup. That's a good meal that has happened. And that even extends to a situation whereby good for bush hunting for wild animals that might be reservoirs for the viruses that or organisms that can lead to epidemic or pandemic. So I want to know what roles does cultural practices play in Thailand and how you are able to successfully implement that excellent model. Thank you all.
Mohammed, thank you so much. I think we ought to, in the interest of fairness, restrict everybody to one question. But you got two questions, so we're going to try to answer both.
I'm sorry.
No. They were both so good. They were both good. Mark, do you want to take?
Yeah, no problem. I'll make mine very brief, so Kang can take the other question. Yes, this did start in the prior government in Tanzania and has continued during the current government. And so, one of the values is in all of these systems that we've tried this out about bringing the data together, also include Albania, Cambodia, Bangladesh, and Pakistan. We have partners who work with the government. So the SACIDS organization at Sequoia University has been able to maintain and work to keep that going despite some of the issues that have gone on with the local government. But thank you for recognizing that this is possible to do in the low-income countries. Over to Kang.
Yes, thank you, Mohammed, for the questions. So we start with the animal health because our experiences from the 2004 avian influenza outbreak, we start from the backyard farming and it spread throughout the country. So we want to specifically focus on that backyard farming and zoonotic diseases that can spill over to human from the backyard farming. And for the role of the cultural practice here, I think it's somewhat similar to in the countries in Africa. So some of the communities, when their animal dies, they prepare the meals, which is we during the training we also discourage them to do that because it could be the cause of another spillover and it's still happening. And but what we are doing is not try to prevent them from eating dead animals, but try to protect and spotting the sickness of animals before it's dead and try to treat those animals before it dies.
Thank you, Ken. We have a question that's come in from Slido from Alan Craig. For Mark, thanks for your comments. I agree that a One Health approach is very important. I don't think that's the norm in most countries. How can we make this happen?
Yeah, I agree with you. Participatory surveillance, the reason we've focused so much on it is it really is the opportunity to change the norms. Because if we start with our traditional surveillance systems, they're so siloed in most countries that it's hard to break down those silos. But when we think about engaging directly with the public and bringing the government along in that process, because ultimately they are responsible for surveillance. And I think Kang's example and Chinese example goes to show you that it was a high risk effort for the government to think about putting resources into an unproven model. But because they were there from the beginning, helped design it, and now completely own it, that's what we need to be doing to bring One Health into the countries. We need this risk capital that philanthropy really offers a great opportunity to bring to these countries, but doing it in a way that the ultimate goal is to be able to have it be a self-sustaining system. So we see participatory surveillance as a great entry point into One Health, because if you engage directly with the communities, they care about their environment, they care about their animals, they care about their people, and that's where we can have the greatest impact, and we can bring the government systems along in the process.
Mark, would you compare the cost of a participatory surveillance system at a national level with the costs that are currently the current costs for national surveillance systems? Just give some idea of the difference in the scale of costs.
Well, I just remember that there was a study not too long ago that estimated that it would take $3.5 billion annually to have disease surveillance system on the globe. And I just remember thinking at the time that all we're looking at is the current way we do things. And if you think about doing systems like engaging directly with the public and start building those community-owned systems, they are a fraction of that kind of estimation. And then, once you have those systems, I'm not sure people followed what Kang was showing on the one slide, but what's revolutionary in what they're going to do in PAW-DD is we know things like sewage surveillance has really helped with COVID. Well, they're taking the PAW-DD system and they're going to do sewage sampling in animals. And the benefit of doing that is they also have the data of any outbreaks that are happening, not only in the animals and the humans. So they're going to be able to link epidemiological data directly with doing that sewage surveillance. So even adding on things that are doing metagenomics and diagnostics is also more cost effective because it's being linked to actual events within that community. So I think we have a great opportunity to reduce the overall cost of surveillance, but it really matters that we start implementing these. And just quickly to respond to Emily's issue about socializing these issues and why they don't show up in some of these other measures like the JEE and the Global Health Security Index. I mean, part of it is the data that they're looking at in order to do those kinds of evaluations don't really take into account these innovations. So we just hosted the fourth international workshop on participatory surveillance in Cambodia, which resulted in that map. I put the link in there. We're trying to socialize this by having a living document that any new system that pops up will be populated on the map. And we hope that that will help foster a greater awareness and that hopefully some of these other indices then will include these kind of innovations. Thank you.
Thank you, Mark. And as Mark points out, there are a number of publications and the links to them that have been put in the chat. Please look at those and copy them over because sometimes the chat disappears when the Zoom call ends. We're also getting a number of calls and questions from various mechanisms. Please keep that up. That's really most satisfying for everybody on the panel. Nomita Devi.
Thanks, Larry. And thank you, Chane and Kang, for your talks. I wanted to give you the opportunity to unpack this sentiment and the comments that are coming up about the fact that it is really hard to break down these silos and have sectors talk to each other and let alone talk to each other, actually share their data in real time. If either of you could speak to what it takes to develop that trust and willingness to share the data across sectors, I think it's clearly not the flip of a switch. And so I think elaborating on that would be extremely helpful.
I think we'll give that question to Chane if you're willing to take it.
Thank you, Nomita. Thank you, Larry. Yeah, so the data sharing part, it's not that magical because as we know here, we're working with human. As a human cooperation is one of the toughest one, and human and animal have I think in Cambodia, for us, we're fortunate that our team has been collaborate both with human and animal health in parallel, and has established a trust and relationship with both the human health and animal health. So I think with that, and also with the needs of in terms of the One Health and support from the community in terms of human and animal collaboration. So we the relationship slowly lead from discussion to agreeing to the data sharing to the more systematic way on the system itself of the data sharing. So I think it takes time and it takes a relationship. It takes the trust in place and also all the supportive environment also to cultivate that to make it happen. And of course, it would not be happen if the both human and animal are not willing to cooperate. So yeah.
Thank you, Chane. T.H. Sowapak, thank you very much. And your question, please.
Okay, thank you very much. I'm from Thailand, Department of Disease Control, Ministry of Public Health Thailand. That's great that I can hear Geng from PODD to talk about in the what in this like the benefit from PODD, because in the I am the one that in the use information from PODD, because in the our responsibility is kind of like investigation when we see like an abnormal event that so have like a signal of the abnormal event that occur in the communities. Okay, that is a benefit from the PODD. The one thing that we can observe, and maybe in the both of in Cambodia and in Thailand can share, because in the PODD it's kind of like they work in the community in the rural area. So that means village health volunteer is kind of like an influencer. It can lead the people in the community to understand the context, the important thing about in the how to report abnormal event that occur in the community. But some disease that occur in urban context, this is a difficult, because in the like a lifestyle of the people when they live in like a urban area, they might not like engage much with the community. So I would like to ask in the what in the how we can engage like the people in the urban lifestyle in the urban context to share and like a report on in there any abnormal event that occur. Thank you.
Thank you, TH. I'm going to ask Mark to answer that question, but I'd like everybody to take a look at Emily's comment in the chat, calling attention to the importance of the dashboard and reminding us that as good as all these other systems are, you have to have a method for displaying the results in a way that people can understand it. And we're going to go to Marty Citrin next, but first, Mark, do you want to answer TH's question?
I'm sorry, I'm not sure exactly what the question is.
TH, would you repeat your question? Repeat it, please. I think you're on mute.
Okay. My question that in the how we can like engage the like people in the urban area, it's not in the rural area, to have like a more participating in the reporting or in the early detection in community, because in the different context.
Yeah, sorry, I missed that part. Yeah, I think there's an opportunity with participatory surveillance to serve any community. I mean, what we did was, you're hearing about two rural examples, but even during the World Cup and the Olympics in Brazil, we implemented participatory surveillance for the first time at a mass gathering that allowed anybody coming into that. And we were very interested in that because people come from all regions of the world and then they go home to all regions of the world. So people participated during the event and then they continued to do that for 2 weeks after. So I think the system itself allows you to think about any community to engage, and it's just a matter of having, you know, a partner who wants to work in those particular areas to adopt that technology. In Thailand specifically, in the PODD system there, they've created the Open Data Toolkit, which is really great because it allows anybody to take, you know, this idea and build your own system, and they do all the engineering on the background, and they've created a very simple form. So anybody with an interest in doing urban surveillance, even in Thailand, it would be very easy to build a tool to serve that community using this Open Data Toolkit. And, you know, all of the engineering part is done thanks to the work of Open Dream. So I'm sure Kang could help you more than the response to, or my answer to your question. But yeah, it just really, it's the will and the desire to engage a particular community, but the tools themselves work across any population.
Thank you so much, Mark. We have one last question from Marty Citrin, then we're going to do a rapid round of one question that I'm going to ask each of the participants. Marty?
Well, firstly, I want to congratulate all of you for these excellent presentations and inspiring and hopeful. I want to dig a little bit deeper because something Mark just referred to, and I think I heard from all of them, is you know, the value of participatory surveillance not only involves an educational component of the population, but understanding incentives and how they're aligned. And we often see in big threat situations or situations that don't have immediate intervention answers, the consequence of the actions or the uncertainty of the outcome of the actions can also destabilize some of those trusted relationships. How do these systems, how can they work in a setting where the alignment of incentives may change? And that's whether it's political incentives, the population's incentives, the public health incentives and the types of interventions, or the private sector's incentives. We certainly saw this a lot during COVID, where there was tension between them rather than alignment. How do you guys struggle with that issue?
So the alignment of incentives, I think this is a really critical question, especially as regards to sustainability of these systems. We're going to run out of time, so who would like to answer that question? Mark, then, would you just answer?
Certainly, I mean, for participatory surveillance, the key is that it has to be bidirectional. So, we know from Public Health 101, the only thing that really matters is if you give feedback. So all of these systems are built on the idea that no matter what the system is built for, whether it's specifically for flu, whether it's for, any zoonotic disease, the ultimate goal is to give very valuable information back to the community. So one of the first systems we built was Flu Near You in the United States to test out this model. And if you were a participant in Flu Near You, you got very accurate information about where you could get a vaccination in your community, other links to important resources. And the feedback that we would get in the annual surveys, as long as I'm getting something back from participating, that's all the incentive we need. We didn't have to pay people to be part of the system. It really was just respecting the fact that we appreciate you being part of the system and we're here for you. And so, we heard early on when we went out to visit the first people using the PAW-DD system in Thailand, as well as the hotline, and we would ask farmers, like, why did you report? And they're like, because somebody did something. They came and checked out my sick animal. They came and did testing. So ultimately, the incentives have to be aligned with the purpose of the tool, but feedback itself goes a very, very long way with keeping people engaged.
That's great. I think that's the key. So we have 5 minutes left, and then there's going to be a 10-minute break. Before we go to break, a lightning round. I'd like all of our participants to forget what country you're from, what system you've been advocating, and look at everything that's been discussed today and think about our experience with COVID. And in a very short 1 or 2 line answer, you've got this now global audience. What are the 1 or 2 most important things you feel are lacking in a global situational awareness system? And what would you tell the world are the key and most important issues? And I'll start with Ken. Ken, I'm going to toss that question to you first.
Yeah, thank you very much for the question, Riley. I think what lack of the global arena, I would say the embracement of the One Health approach. Whenever we try to talk about this, it will be either human health or animal health, a separate discussion, and I think if we could have the mechanism to give the global audiences the benefit of working together and doing this One Health approach, regardless of the tools, just the approach. I think that's really important part, and it's still like in the global arena.
Shanae, would you like to take that next?
Thanks, Larry. I think one of my head, it would be the data, of course, like the participatory surveillance, but also like the data sharing among One Health partner. So that is very critical to have it on time, to have it like the outbreak, even the case, and so on, sharing and collaborate and jointly work on that before the case becoming like the big outbreak happening. So that part, I think even our work in Cambodia show that it takes some time to get to a certain point to agree. So but if we still lag behind that, I don't know how fast we can run after the next disease, because the One Health, the disease nowadays, it needs the One Health partner to work together and hands in hands and sharing data and collaborate, move on together. Yeah.
Mark, how would you answer that question? What
Well,
are the most
I would first say when it comes to COVID, Larry, I wish I could forget what country I'm from. But, in thinking about from a global perspective, the key is we need systems that really do engage the population on an ongoing basis so that when we have the emergency, and I think the Cambodia hotline is the perfect example, they were able to dial that up and not only, use that to be finding cases, but they were very instrumental in helping with, the contact tracing. If we don't engage the public to really be part of the solution on an ongoing basis and really get them to be excited as citizen scientists about, what's going on in their environment, people who go out on hikes could report, take photos of, dead or sick animals, ways to really think about One Health that people are really interested in public health. I mean, that's what we hear over and over again. They get excited and even many of the technologists that we brought together to do these epi hacks and work with their governments. I mean, Kang is one of the perfect examples. They've gone on to get masters in public health because they get so moved by what is the potential. And there's so much potential for the public to be interested in it, but we've got to get them excited about it in really fun and interesting ways on an ongoing basis so that when there is that public health emergency, not only are these tools going to help us detect, cases faster, but we then have a direct avenue to response. We can be giving them really helpful messages about, the public health measures like, mask wearing and social distancing and being outside and all those things that would come from a trusted source because they were part of that system and feel some, allegiance to that because it wasn't something that somebody just popped up during the emergency and said, hey, you need to join this. It's something that really is part of, their everyday engagement.
Thank you, Mark. And we've only got 2 more minutes, so I'm going to summarize. What a wonderful panel, what a wonderful action incentive for everybody. Thank you all for participating. If I could summarize, I would say we're about to embark and be reminded of the boom and bust cycle that we have when epidemics and pandemics hit us. It's critical that we remember that these systems have to have sustainability. They have to have sustainability when there isn't front page news every day about an outbreak. And sustainability requires public engagement and public trust. Without public engagement and public trust, public health just does not exist. And we've lost a lot of that in this pandemic. We have to regain it. We also have to understand the difference between great ideas and inventions and the dissemination of those inventions globally. Pandemics are different than anything else. If we have a single break in the chain, the worldwide chain, that's where the virus comes from. We have to understand that everything we do in one country has to work everywhere. And I think today's panel has given us a really good example of that global participation. Thank you so much. You have a 10-minute break now, and then we'll be back and talk about other things.
sessions that really, I think, got a lot of us thinking. I think we've had some great reflections on the Jamboard. And just a reminder to use those Jamboards to add your thoughts. All of that that rich content will be added into the reports that will be going forward and publishing, but also will inform our next session on June 9th, which will also be captured. So we're going to start with our next exciting session, and the goals of the next discussions are to review that not only the success and failures, the use of assessment tools, but also identify the outstanding gaps and determine those critical areas for action to sustainably improve capabilities, which is a big part of our entire symposium, our three-part symposium. So our first session will be Global Health Security Capacity and Functionality Assessments, which will be moderated by Amir Ikram and Jessica Petrello. Amir is the Chief Executive Officer of the National Institute of Health Pakistan and the National Coordinator for the National Command and Operations Center for COVID-19. Jessica is the lead for a new team in the Emerging Threats Division at the United States Agency for International Development, or USAID, that is focused on global health security. The second topic is countries and organizations' experiences in preparedness and response planning. It will be moderated by Sao Pak Hinjoy, Erwin Humberto Calguero, and Arminder Deol. This session will also be available on the live stream for webinar viewers. And Sawapak is the director of the Office of International Cooperation within the Department of Disease Control in the Ministry of Health in Thailand. Erwin is a research professor at the Research Center of Health Sciences, School of Medicine at the San Carlos University in Guatemala. And Arminder is the head of data science and advanced analysis at the Coalition for Epidemic Preparedness Innovations, or CEPI. And I'd like to thank all of them because they are key on our planning committee. So thank you very much again for your thought leadership. As I mentioned before, during each session, one of the topics will be live streamed for the webinar audience. And for this one, it will be the countries and organizations' experience in preparedness and response. And for those watching the webinar, please use the Slido link to access where you can enter your questions for the speakers. Also note the recordings of all 5 of these individual sessions will be available afterwards on the National Academy's website. At the end of this second round of concurrent sessions at 11 a.m. Eastern Standard Time, we'll be rejoining everyone together to discuss the highlights from all 5 sessions. So at this time, I turn it over to the National Academies to Zoom us into our rooms. Remember to use Slido and the Jamboards.
In our section, we have in the T, our team, the moderators. Okay, Erwin and Amanda, you can introduce yourself, please.
Hello, everyone. I'm Erwin Calwa from Guatemala, and I'm very happy to be here with you. Happy to interact.
Thanks, Evan. Hello, everyone. My name is Arminder Diol, and I'm the head of data science and advanced analysis from CEPI, and happy to be here and interact as well. Thank you.
Okay, and today we have honorable speakers in the 4 speaker that join in our section that you will learn from the country experiences in the term of the preparedness, response, and planning. And we have in the two speakers that from Peru and from Brazil. For Peru, we have in the Dr. Alexis Hawkins. He's a medical advisor to the Deputy Minister of Public Health Peru. And we have in Singapore, we have Dr. Jeffrey Carter. Dr. Jeffrey Carter, he is the director of the National Tuberculosis Program and Public Health Advisor to the National Center for Infectious Disease in Singapore. And he also been the current chair and Singapore country coordinator for the ASEAN Health Cluster 2. That's meaning they're in the ASEAN member on in the 10 ASEAN, and now in the is a cluster 2. This about in the emerging infectious disease and also in the health emergency. And we also have in the Dr. Ari Adalian. He is a regional advisor and head of the health system in emergency lab and laboratory and World Health Organization regional officer for the Eastern Mediterranean. And we also have Dr. Julio Corda. He is a professor of in the faculty of in the medicines, and so he was a chief of in the communicable disease in Brazil during the video within the COVID-19 pandemic. Okay, and now we have like all in the 4 speakers. And Erwin, you may start for like a have a question or would like to ask our speaker to share their experiences. Erwin, please.
Thank you. So we have devised in such a way this meeting today so that we can have the interaction with you as participants. So our panelists will be asked a couple of questions, and then we will be moving forward with your questions so we can come up and take the most advantage of the experiences that we have heard these wonderful 4 countries that are sharing with us what they've done for SARS-CoV-2 and what they are envisioning for future pandemics. So Alexis, thank you so much for joining us. And we would like to ask you first, could you describe us the Peru experiences, including its relationships with other countries and multidisciplinary efforts in preparedness and response planning to address SARS-CoV-2 pandemic and any other future epidemics and pandemics from known as well as unknown pathogens? Thank you so much.
Hello everyone. Since the Peru was one of the countries most affected by COVID-19. However, the service had to be reorganized and information system integrated. For the public health system was deficient and not prepared for a pandemic prior to COVID-19. However, service had to reorganize an information system integrate. For example, prior to COVID-19, the oxygen supply in the regions was unknown, and so the information has to be integrated into a dashboard to be able to intervene promptly in the event of shortage. Another example was the decentralization of the molecular biology laboratory. Prior to the pandemic COVID-19, we had only one laboratory in Lima to process molecular SARS-CoV-2. But currently, there are 127 molecular biology laboratories in Peru. And in addition, the implementation of the genomic surveillance allowed us to know the circulating variants and the identification of a new viral lineage during the Mpox epidemic. The other problem in Peru was the frontiers were officially closed to control the spread of the virus. However, due to our geographical landscape, the migration controls were not effective, particularly from north to south, where migrants continued to coming into Peru. Therefore, the spread of the virus was a challenge. And the CDC of Peru encouraged our collaborative work with neighbor countries for border surveillance and information exchange according to the international health regulations. After the arrival of COVID-19 vaccines, cross-border vaccination campaigns were carried out jointly with Ecuador and Brazil. This is part of the experience in my country. It was a difficult work to control this pandemic, the COVID-19 disease.
Thank you, Alexis. And just one more question, just to add, the multidisciplinary effort in Peru. So, because at the beginning, you're thinking more from the Ministry of Health, there were other disciplines also involved in this that help you out and you have to coordinate with?
Yes, we have well, the problem in Peru is the health system is fragmented, and we have a Minister of Health and the force armed health system and the private system too. But in this moment, in the pandemic, COVID-19, all the actors works in to control this problem. The community was an important work in this problem, in this disease health problem.
Okay, thank you, Alexis. And please also remind for everyone that is looking at this through YouTube that they can also provide comments on Slido and the Jamboard in case they want to make their question. We want to be able to share this with our participants. So Alexis, then the other question is, what tools have helped Peru to measure capacity needs for what was SARS-CoV-2 and will be helping you for future epidemics and pandemics?
Well, the surveillance, the force from surveillance in the others for the other disease, and the laboratory for detect other disease about COVID, for example, Mpox or the avian flu. In this moment, it's a work with not only the Minister of Health, include the others ministers. It's a work, intersectoral work in this moment.
Thank you, Alexis. So Supak, it will be now your turn.
Okay, thank you.
Thank you.
And now we can hear like the experiences that occur in Peru. And now I would like to move to in the view of in the regional level. And I would like to ask Dr. Jeffrey to like provide for the term of in the how like a relationship between like Singapore and how we work together as in the ASEAN health cluster too, in the term of in the preparedness and response. That means that Dr. Jeffrey can explain this kind of our mechanism in ASEAN. Dr. Jeffrey?
Hello.
Okay.
Yes. Can you hear me well? Okay. Yeah. So the 10 countries of Southeast Asia, and that we call ourselves ASEAN as the regional organization, we have a long history of working together in terms of sharing best practices, learning together in workshops and training programs across many different areas in health. And so over the years, different networks have been established. For example, there is a network of emergency operation centers, which enable the sharing of information whenever there's a new incident or something that is useful to share with the other countries. So this is shared online. There's also a regional the risk assessment and horizon scanning center currently based in Indonesia. It previously was based in the Philippines, which publishes risk assessment reports, which are then shared with the 10 member countries to provide the latest updates on COVID-19, until recently, also Mpox and so forth, basically to share information. There are many other mechanisms as well to which enable the 10 countries to increase their capacity. So for example, there's another network which deals with field epidemiology training programs. So the different FETPs in the country, in the region, regularly come together to again share best practices, to meet together, to share notes about how they train their field epidemiologists and so forth. So this is ongoing, and I would like to also share that an exciting development that we in ASEAN are looking forward to is the establishment of what we call the ASEAN Center for Public Health Emergencies and Emerging Diseases, a mouthful, but we call it ACFID for short. ACFID will be a regional center that will focus all the training programs, information sharing, and so forth for the region. And of course, we have many partners who support us in our work. So this can also facilitate the partners coming in to help ASEAN. So just quickly to say that the ACFID will be based in 3 countries, in Thailand, in Vietnam, and also in Indonesia. And each country would sort of focus on a different area in terms of preparedness and capacity building, and also surveillance and detection. So perhaps that's what I can share for now. Over to you, Sopa.
Okay, thank you, Dr. Jeffrey. And Dr. Jeffrey also highlighted the ongoing center that we call ACFID. This is like a hot issue in our region, that how we can work together for the detection, prevention and response. And now we hear from the ASEAN, right, from the regional in Asia. But I would like to hear from the Dr. Ellie that you may share about the kind of how the WHO MLO can work on the axis together within the at the regional and the country level in the your region. Dr. Ari, please.
Thank you so much. Let me please first define the context where actually we are working in. The Eastern Mediterranean region of WHO consists of 22 countries. In East, we have Afghanistan and Pakistan, and it expands to the west to Morocco. And that's a region, we call it a catalog of the emergencies. And basically, the country is very much exposed to different type of the natural hazards. We have experience of large scale natural disasters, let me name it, earthquake, floods, and also dust storms. And from the other side, the region is well known for the armed conflicts. We have 19 graded emergencies that require WHO support, including 8 countries that are struggling with the protracted conflicts, some for decades. We have 13 million forcibly displaced population, and 46 million migrant workers. So basically, in the recent crisis in Sudan that actually is going on, more than 1 million people were displaced. 200,000 fled to neighbor countries. So in this context, basically, we are dealing with countries that are already have weak and fragile health systems. But at the same time, fortunately, we have rich countries with well-established and developed health system. As an example, taking the COVID pandemic, basically, when the pandemic started, WHO defined a system to come up with the 3 levels of response: headquarters, regional level, and country level. And we established at the HQ and the regional level incident management support team, inclusive of all the related technical and operational entities and expertise. At the country level, WHO established the incident management teams or similar emergency response mechanism. However, as you know, it was not an easy situation, and all of us have gone through that. The pandemic was novel and fast changing, and in fact, making it difficult for WHO to provide up-to-date and evidence-based technical guidance to the member state. From the other side, there was an unprecedented disruption of the supply chain. What I mentioned, that the weakness of the health system capacities, specifically in the FCD settings we had, basically that was added to those challenges. Inadequate clinical and logistical systems and supply chain, insufficient regional and local production capacities and capabilities, especially when it came to the production of the COVID vaccines. In all those 20 countries, also, we faced with the variable quality of country level leadership when it came to the Ministry of Health. So everybody think of the Ministry of Health as the leading agency. So that's the ministry line that lead the pandemic. But almost in none of the country was the case. Ministry of Health all played significant role, but in the actually umbrella of the highest level of the government and more powerful ministers. So in general, in this political situation, one of the aspects we always had the challenge was the availability of data and data sharing by the member states because of the different reasons. Being a matter of the national security, risk reputation of their own response, etc. But however, the IMST that I mentioned helped WHO EMRO that showed an inclusive and effective leadership. Specifically, all the senior managers of the organization attended, like I would say, maybe more than half a year, every day in all the incident management system meetings. And the countries felt that this is the way that WHO wanted to provide the support as much as possible. Operationally speaking, we have a logistic hub in Dubai that facilitates stockpiling and the centralized logistic and provision to the countries whenever needed. So I would stop here and would happy to answer any other questions.
Thank you, Dr. Ali. And we hear from like a regional level, and then how Dr. Ali also touched about in the multi-sectoral approach that in there, and now everyone thought that in the COVID-19 that the health sector is like a lead for in the response. And Erwin, I think in the we still have like one country, Brazil, that in there can share. Erwin, please.
Thank you. So then we have now the possibility to understand how Brazil responded to this pandemic. And so we would like to ask Julio to please describe Brazil's experiences, including its relationship with other countries and multidisciplinary efforts in preparedness and response planning to address SARS-CoV-2 and any other future epidemics and pandemics from known as well as unknown pathogens. Thank you, Julio.
Thank you for the opportunity to be here. It's a pleasure to speak about Brazil preparedness and planning for health emergency. And as you know, Brazil is a large, diverse country, and in the last year faced enormous and different health emergencies of the years, and develop a robust strategy to take it with this challenge. And you can remember in the Zika emergency in 2015, Brazil faced a significant outbreak of Zika virus, which pose a serious health risk, and it's a particular in the pregnant and the newborns. And based on your system, you have this unified health system that covers 200,000 million people, 7% of the population using the system. And during the Zika outbreak, you can deal with a good response, especially to understand what occurred during this time, to develop a new diagnostic test, to follow up this pregnant human, and to educate the population about the preventive methods. I think during this time, you have a positive example in 2015 during the Zika emergency. But nowadays, you have the COVID-19 emergency that just ended. And as I already commented, Brazil have this unified health system that have good electronic system for surveillance. This is a good thing for us. And during the COVID-19 pandemic, you were able to expand, especially your health infrastructure. And this include labs and investing in the research, especially to produce vaccines in Brazil. We have two public labs, Oswaldo Cruz Foundation and Butantan Institute, that produce Coronavac and AstraZeneca vaccine here in Brazil and help us to begin early the vaccination in the country, but also have this unique electronic system that the patients was reported, the lab was reported, and you can engage with the unique identifying number with a vaccination system, lab system, and a notification system. You have a specific problem in Brazil during the pandemic because you have 10% of the deaths and 3% of the population in the world. And these occur especially because of poor coordination, especially in the federal level, because Jair Bolsonaro, the president during the time, don't support the response in Brazil. And each state needed to organize your response, needed to deal with the communication. I think the worst scenario occur in the states that support the right party and don't provide no pharmacological intervention, don't support the vaccination when they begin this vaccination. And it's important to us to learn with this. And but also to understand that in Brazil, because we have this federal system and this unified health system is so strong that even you didn't have, even with poor communication that occur in the federal level, you were able in some states to have good response to COVID-19 emergency, especially led by the state level stakeholders, and provide good support for the population. I think this is my initial comments, but you can discuss some aspects for the future, what you're learning and what you can improve for the future.
Thank you, Julio. I would like to ask you a little bit about the multidisciplinary approach of this, because we always think this, especially in a region like in America, Latin America specifically, that when you face a pandemic, it's basically something of the medical doctors. But this is, so one of the things, this goes beyond that. So what will be your thoughts in regards to how Brazil was able to interact multidisciplinary and the takes of this?
I think for the health, you already have a good interaction because you have this unified health system and you have like the basic primary teams that you work in the community. This already been in course in Brazil, and it's very easy to work on this. You have several community technicians that perform evaluation in the community, in the house, and follow the participants with the patients with the COVID-19, check the vaccination status. But I think the one important lesson for this time is the communication. I think you need to have a better communication team integrated in the health system, because all this, when you look at the non-pharmacological intervention and the people don't want to use the mask, the people don't want to get the vaccination, basically because they receive misinformation, fake news by WhatsApp, by social media, and the government, it's so bureaucratic that don't know how to lead with this. The new way of the communication and how to reach this poor population that only receive information by social media. I think integrated this communication and the people that know this, how to communicate the emergency, how to reach this specific population, poor population, it's a key for the preparedness for the next emergency.
Thank you, Julio. Then my last question for you will be, what tools have helped Brazil to measure its capacity needs? Now, you mentioned that's done with previous, like Zika, but like based on what SARS-CoV-2 brought here, which was in a more global pandemic, what tools have been used?
You have a national state plan for emergency. Every state needs to have your plan. In the national level, you need to have a plan for the next emergency. And during this process, you need to review your procedures. All the time you learn with Zika, you learn with influenza, but you learn also with COVID-19. I think in Brazil nowadays, you have a new government and they have planned to have external evaluation about this emergency plan. I think it's very nice that the country can perform this external evaluation, how the preparedness for the next emergency that probably occur as soon you know that you have all these climate changes and more integrated about the human and environmental, that occur, and you need to prepare better for the future. And how you do this, evaluate your national state plan and do this external evaluation. I think nowadays it's more easy, especially in the political context that we have in Brazil, to perform this work and have in the country level more some evaluation and improvement in this preparedness.
Thank you, Julio. So I think this gives like the chance to resume that we already were the questions we had prepared. We have now questions from those participants. So we have 2 already written, and then you can raise your hand so that they can share. And we'll also be looking at some other, those that are looking through YouTube that actually can send us their questions to Jamboard or Slido. So, but will be okay if we begin, since Julio brought up the thing about climate issues and some other issues. Should we like probably begin with that question to all the panelists? Be that okay?
Yeah, sure. Yeah, sure. In the and now in the we can see from in the the chat box that's in the ask about how we can go beyond to in the climate change. It's just not because like now in the main context is we in the COVID-19 response, and now in the we ask for the issue under the climate change, and I think like a multi-sectorality or in the one health approach, maybe in the one that in the we can answer that. I think in the our speaker. I would like to ask the question to Dr. Jeffrey, because in the from that in the chat box, they asked about what any a specific action that need to address preparedness and response within the context of climate issue. Because in the last month, we have our ASEAN One Health Declaration. Maybe Dr. Jeffrey can tell more about how we can use our One Health Declaration to address this kind of the climate issue. Dr. Jeffrey, please.
Yes. Yeah. So at the ASEAN Summit, which was attended by the leaders of 10 ASEAN nations, one of the declarations adopted was a declaration on One Health cooperation, and this provides the highest level of political commitment to ensure that there is support at the highest level for One Health activities. And I think it goes without saying that it is absolutely important that the different sectors are able to work well together, are able to coordinate well, and share information efficiently and effectively to tackle zoonosis, food issues, whether it's food safety or food security, many issues that the different sectors need to work together. I also want to just share that at ASEAN, which has organized itself in different clusters, I'm the current chair of Cluster 2, which deals with public health emergencies and emerging diseases. But basically, this cluster takes an all hazards approach. In Cluster 2, we include not just pandemic preparedness and various communicable disease. We include AMR. We include environmental health. We include the medical and health response to natural disasters. So we take a all hazards approach and we tackle it together collectively as a region. So some of the things that I can share from ASEAN. Over to you, Sophia.
Okay, thank you. And that's great that I can hear. We can see from Dr. David Herman that he said that it's great to hear about the One Health initiative in ASEAN. That they we just declare a declaration dealing in the ASEAN summit, right, Dr. Jeffrey? We saw that in the final version.
Yes, during the ASEAN summit, which was adopted on the 10th of May.
Okay, thank you, Erwin. And then I saw some the question too in the chat box, Erwin.
Yeah. So we have one. I think we begin from a question for Ali. So the question says, in the recent Sudan crisis, in this case, we are dealing with countries that already have weak and fragile health systems. We also have rich countries with well-established health systems. When the COVID response started, we established at headquarters at regional levels, incident response systems. Country level, WHO established the incident management emergency response. It wasn't an easy situation. So basically, what challenges you see in conflict areas, specifically when you have to respond? So you have you mentioned Sudan, very conflict, political contexts. So how you approach in the midst of this pandemic?
Actually, let's talk about the Sudan with the ongoing crisis that we are facing. So basically, what is happening in the country? There are two groups of the combatants, violent, taking harsh military actions against each other. That led to, as I mentioned, the displacement of the more than 1 million people, 200,000 fled to other countries. In Egypt, that right now I'm based, we received about 46,000 Sudanese. This is the first time that we have seen the WHO office was looted in the capital of a country. And basically all of our staff had to evacuate the international staff. First, we decided to relocate the national staff to safer areas in the country. But finally, all had to leave the country. So now in the regional office, we are hosting all the colleagues from the Sudan country office. So basically, the first challenge is that presence on the ground to see what is going on, collect data, information, and plan for the response. The other issue is about the access. Always, humanitarian response is about the access. How is possible to actually mobilize the resources and get to the beneficiaries on the ground. So the safety and the security is always a challenge. In availability of the information. One of the questions right now, we are working on that, is about the continuity of essential health services. In Khartoum, the capital, that is like the center of the conflicts, and the other war-affected areas. So the question is that where we get reliable, timely information about the functionality of the health facilities and the services. So these are like the critical challenges we usually we face during response. To organize ourselves for the better coordination and timely response, as I mentioned, we have a system, incident management support team at the regional level, doing the public health risk assessment, grading of the emergency to see what level of the response is needed, and based on that, mobilizing the resources. And one of the first thing is that developing a list of the team for the search capacity to be deployed to the country when is possible. So access, safety, security, and actually availability of timely data information on the functionality of the facility and services, I would name as the high priority challenges. Over to you.
Thank you, Ali. And let me ask one more question. How you will evaluate in such context how the response was and how you can prepare for future? Because somehow we're understanding with the panelists like with Jeffrey, Julio, you, and basically what we are hearing here is that the situation is in complex, but how in those different contexts you are planning to evaluate and how to improve in such a challenging context.
So basically, there are different tools and mechanism, and depends on the nature and the scale and extent of the problem. So under the monitoring evaluation framework of IHR, we have after action review. So after, for instance, a natural disaster or outbreak, basically, we review what went well, less well, etc. It's called after action review. During the COVID pandemic, because it was protracted, we defined a mechanism to conduct intra-action reviews. that now while the COVID pandemic is not anymore a public health concern of public health emergency of international concern, at somehow that after action review should be done. For the protracted emergencies like the conflicts we have in countries like Syria, Sudan, Somalia, Afghanistan, etc., there is a mechanism called operational review that periodically all the three levels of the organization, depends on the grade of the emergency, different teams and stakeholders gather and review the response according to some set of the indicators and benchmarks, and hopefully improve the response over time.
Thank you, Ali. I think there are some questions for your panelists. So,
Okay, and I see the question that asks about like how in the NGO or in the academy or in the like a non-health sector that can contribute the communication. And I think in the Dr. Julio, you already like point out in the how important of in the communication building in the response. And this is the question is to Dr. Julio, and also I would like to Alexis that in there can like contribute more detail in the communication in Peru from in the non-health sector. Okay, Dr. Julio, please.
Thank you for the opportunity to clarify this and special point, especially related to the communication. I think it's a big challenge for us in the future. I think not only government, but other part of the society need to deal with this. And in Brazil, for example, you have like Oswaldo Cruz Foundation. I'm a part of this foundation also, that try to develop as academic institution new programs for specialization and also master PhD program, especially in the health journalists. I think it's very important to building this bridge between the science and the society. The researchers, the public health stakeholders have difficulty to communicate with the general population, and you need to teach this, especially have some formative course for the stakeholders, also for the journalists. Every institution need to have a special vision for the communication to construct this trust, especially in related to the communication. I think several countries experienced this difficult during the response, and for this, I think you need more funding also for NGOs, for academic institutions to work in this specific field. You have this funding during the emergency, but nowadays between the emergency, you didn't have a lot of funding to support these communication initiatives. And I think in the government, especially in the government, because it's a public health emergency, you need to have some special funding to improve this communication in different levels and try to work with the private sector and maybe the private health service to help the public also, and to construct better communication in the health. I think you not deal with this, and the majority of the problem that you face is based on this. Also, it's good to understand that you need a new regulation, especially for the social medias. Nowadays, we discuss this in Brazil. We have a new law that is discussed in the Congress, how you can regulate the media, especially the internet and the social media, because the majority of fake news have more share than true information, and you need to responsibilize the person and the companies that is responsible to share this misinformation, this fake news. It's a big discussion nowadays, I think, in several countries. In Brazil, it's a hot topic, and I hope you can share your experience in the future.
Okay, thank you, Julio. And I think there maybe the thing that happened in Brazil maybe occur in the Peru. Dr. Aresis, please.
Well, fake news were a serious problem in Peru. For example, the use of ivermectin, or the use of auto-medication. And for this, the scientific community has an important role to provide the information based on evidence. So the Ministry of Health has used social media and traditional media to inform these topics or these problems to all members of the public could implement. Not only in COVID spread was contained, also other illness like flu or diarrhea, case lowered by the use of masks and continued wash of hands. And in addition, we have 55 indigenous communities, 48 in native language. We translate message about COVID in 31 language, native language, about how prevent COVID, or about the importance of vaccines in COVID. It was a difficult work to translate this information, to explain these topics in indigenous communities.
Okay, thank you, Orestes. And Erwin, I saw a lot of questions that pop up in chat box. Okay, Erwin,
Yes.
please.
So we have this from Ravi Anuquindi from the University of Michigan. So this is for Jeffrey. Has ASEAN developed some of its own tools to assess preparedness of its member countries? And what metrics are used to assess preparedness for member countries? And be ready, Jeffrey, because we have 2 more questions out of this one. So people are very interested to hear from your experience.
Thank you for those questions. I think first of all, I have to say that ASEAN as a regional grouping is not at the same level, for example, as let's say the EC or the EU. It is more a loose grouping of countries, and we are quite disparate in terms of like socio-economic status and development status and so forth. So it is quite disparate. But nonetheless, ASEAN as a regional grouping has been around since the 1960s. But coming back to the specific question, before the pandemic, all the ASEAN countries underwent the WHO IHR joint external evaluations. So all the countries had that evaluation done, and that evaluation was meant to then use sort of provide information for national action plans and partners to come and support with external aid and so forth. I believe that in the aftermath of the COVID-19, most of the ASEAN countries, I can't be sure, but certainly in my own country, Singapore did comprehensive official after action reviews, reviewing the entire chain of the response, in multiple areas, looking at what went well, what could have been done better, and making use of the information to plan for the next disease X or pandemic or epidemic and so forth. So I believe most of the countries will have done official after action reviews to inform preparedness. Over.
And Dr. Jeffrey, what metrics do you think will be more meaningful? I mean, there are many, but do you think will be more meaningful within this comprehensive action reviews or assessments that they're doing afterwards?
Yeah, I think it's hard to say, what metrics, because, when the pandemic affected so many sectors, right? From the economy to, if you talk about the healthcare sector, to systems which for the containment of or suppression of disease spread, to more broader non-pharmaceutical interventions, to healthcare capacity, to the ability to deliver vaccines when they arrive. There are so many areas that had to be looked at and assessed. So some areas did better. Some areas there are gaps. So it's hard to say what metrics. So it is quite a big assessment in many areas. Over.
Okay, thank you, Jeffrey. And I think the next question, which comes from Claudia Osorio, it's also for all the panelists, and if you want to answer, but it will be good to hear from everyone from your experience in your regions. So she asked, what's the practical value of assessments? So have you heard about studies that investigate assessments results? And well, what do you think about this?
Well, maybe I just add a start off. I think these assessments are only useful as far as you make use of that governments make use of the information to actually act on it. Because I think it's very easy to have the assessments done, but then after that there is no tangible action to address gaps that are identified. So I think that is one big problem that many countries have. The assessments are done, but the after action, the follow-on action is not there really. Yeah. Over.
Thank you. Thank you. Julio, Alexis, and Ali, do you have any comments about this?
I totally agree. Like you need to have the evaluation, the action, and monitoring this action during the time. And it's very difficult because it's sometimes you have change in the policy in the government and change the parties, and they don't want to follow the less recommendation. It's good to have to keep the technicians and especially and the stakeholder involvement on this evaluation, and also commitment with this improvement. It's part of the convention also. It's also how the Minister of Health, it's part of the system, understand this evaluation, understand this recommendation. And you needed to push for the formation also for the stakeholders to understand the importance to implement these recommendations.
Thank you, Julio. So then there was another question from David Heyman who says, ask, so how do people work in countries when a large part of their healthcare services are from a private sector? Anyone that has a comment? Yeah,
I can begin with the comment because in Brazil, the majority of the population, 80% of the population, use the public system, but you have a few ones that use the private. It's the regulation. I think you need a good regulation to the private sector follow the public sector, especially about the information, the notification, the lab test. And here in Brazil, you have Anvisa, this is your health regulatory agency, and the Minister of Health recommendation. And you have some Anvisa go to this private sector and have some auditing on this. And if you have any problems, they pay some. They have some restrictions to continue to provide this service. I think the key message is the regulation and have some fiscalization for this offer.
Thank you, Julio.
May I?
Yes, please. Yeah.
So basically, one comment related to the previous question, I was on mute, and on the use of the assessment, actually, I'm more optimistic. So I think the countries use the results of the classic assessments that also Jeffrey mentioned, like for instance, JE after action review. However, that use of the assessment depends on first the capacity of the country to absorb and implement. The second is that the world is keep changing. You know, when the COVID, the pandemic happened, all the world faced the new challenges. Okay, so that requires that basically we keep updating our assessment tools, methodologies, metrics, etc. One side, from the other side, work with the countries to enhance their capacity. For instance, what we learned from the IHR implementation, we learned that there are some gaps in the implementation and also in methods. So basically what WHO did, establish a kind of the IHR amendment technical working group to review that, and came up with a list of the areas that could be improved. And the first set include those related to the governance and leadership, where the IHR focal point is placed and positioned in the government. And the other recommendation related to the notification, warning, etc. However, what we learned again from all these assessments, they are focused majority on the emergency preparedness capacities. Somehow not see them as an integrated part of the overall and national health system. So that was one of the main lessons learned that led us to come up with something called UHPR, Universal Health Preparedness Review, to not only see that emergency preparedness and preparation for the future pandemics at the country level, but in relation with the regional and global partners, stakeholders, and actually systems. And Thailand was one of the countries that conducted that voluntarily the UHPR. And I think Swawapak can comment on that. Over to you.
Okay, thank you, Dr. Ari. And I think in the UHPR is one kind of in there we have a lot of like health and non-health sector to review what have we learned from the COVID-19 response. And the question that this is would like to ask Dr. Ali too, because in there I can see that in there they ask that like we have many tools, we have like many assessment, and those kind we of course a diversity of the discipline. It's just you can tell us that in there like find like an interaction review or in the other assessment we of course that in the like other discipline to join during the review. Ari, maybe you can tell us about these experiences.
Actually, the question is that if in the assessments we work with other experts, if that's related to Kavita question on the chat box, yes. So basically, ideally, yes. So we don't have a public health emergency that the classic public health people or Ministry of Health is the only stakeholder. So ideally, whatever type of the assessment we need, automatically we bring other stakeholders together. GA is one of them. And whenever you conduct the JE, basically you bring all the sectors and stakeholders in the same room to discuss the different technical areas. Can be related to the security, can be related to the transportation, can be related to the cross-border collaboration, etc. UHPR, just you mentioned that you brought everybody together. It's a universal Universal Health Preparedness Review. And one of the main lessons learned from the COVID is that even the countries that with the high score or highest score of the JE, basically they failed at some point in the effective response to the pandemic. And that was basically, it was the leadership was coming from somewhere else. That was not with the Ministry of Health and Public Health people. So basically, we as a public health community, we should acknowledge that almost there is no outbreak that we are in charge. That's a high level, depends on the level of the extent of that outbreak or pandemic. It is a high level of the government. And there are many key stakeholders involved that have, in addition to health, other right priorities. I would say right priorities, like the economy of the country, safety and security of the country. So putting all these together requires an effective communication between us and them. And then having a governance in place that where this IHR focal point is located. Over to you.
Okay, thank you, Ari. And Erwin, I saw the question from Slido that in the formulate Bridgewater, they asked for in the maybe in the to Julio and Alexis. How are your countries using medical mobile units to reach out to vulnerable populations in urban or in the rural area for healthcare, as well as during the disaster or in the emergency response like a pandemic? Okay, this is question go to Alexis and Julio. Alexis, please.
Well, we have an intervention with mobile units to research molecular samples to COVID. It's a bus that this bus is implemented with a laboratory. And the name in Quechua is COVID Masca. I found the COVID. And with this bus, we have a lot of take a lot of samples to identify the COVID in this pandemic. The other experience is in cities with difficult access or with previous problems with climate change, for example, with the rains or with problems in the health system. And we have a multidisciplinary team this team go to this area to attend the people in this area.
Okay, Julio.
In Brazil, we have this primary health system that nowadays you have some people that is very difficult to reach. Indigenous population in the north, some prison population also, and you develop a special team, primary care team, to assess this population. In the indigenous reservation, you try to work in the multidisciplinary team with indigenous population that maybe have some nurses and health care workers that can be integrated in this team, in this mobile team. But recently, you have a huge increase in the Yanomami reservation that you face a huge malaria outbreak and desnutrition also, and you're able to mobilize a rapid response team from the central level with the partnership other governmental institution like Fiocruz but also to work with the national health force that are have in the federal level. In Brazil, we have these primary care units that it's responsible to take care for this vulnerable population. But sometimes, like occurring the Yanomamis, the miners take out this health population and needs a federal intervention in this specific area, in the indigenous reservation. And in this time, the federal send special teams to deal with the emergency in these special areas.
Okay, thank you, Julie or Irvin. I still have, I think there's a lot, I still see there are a lot of questions. Okay.
Yes, and we have just few minutes to end up. But I think so. One was from Lisa, which was asking how your country is succeeding at this coordination tension that sometimes happens. And if we can finish up with that, we will ask each one of your panelists to share with us probably two specific key aspects that you think are needed to be taken into account for preparedness, and some of the critical actors that you think are important based on your experiences. And with that, we will wrap up because it's almost 9. Yeah.
It's for me, the question, or?
Well, actually, it's the question was for everyone. If in such so when you have emergencies and outbreaks coordination, who's in charge of that is quite messy. So how are usually the countries succeeding at this coordination tension? Like from the Brazil perspective,
Yes, in Brazil you have this experience. You have in the federal level. They not follow WHO recommendations, especially no pharmacological intervention, not support the vaccination. And the good thing is the Brazilian system, you have different levels. You have the municipality level, state level. And in these different levels, you have a special coordination. I know that is difficult to lead with this because in general, in the emergency, you have only one coordination, and this coordination leaded the response for the country, but Brazil is a big country, and you have this special system, and this save a lot of lives in Brazil because some states have a PAHO support, Oswaldo Cruz Foundation support, and develop your approach to deal with the emergency, and like improve the communication and have a good emergency plan. Follow no pharmacological intervention. And I think when you see the Brazilian data, you can see this difference. Have some states that perform better than other one. And probably because in the state level, the coordination is better for some state compared to another ones.
Thank you, Julio.
Well, in Singapore, perhaps I can share. Basically, there is a very well-established crisis structure at the whole of government level, where all the government ministries and agencies are represented. There are 2 levels. One is the ministerial level, which looks at it more strategically and politically, and then there is they are supported by senior civil servants who look at the operational implementation of plans and responses. So it is a common crisis system. So any type of crisis, this same structure would kick in, and depending on the nature of the crisis, different ministries will take the lead. Over.
Thank you, Jeffrey.
May I? This is Ali.
Yes, Ali.
Yeah.
Thank you.
So basically, Lisa is absolutely right. As a experienced emergency person, she's absolutely right. Coordination always is a challenge and will remain. Okay, that's the nature of the facing an unexpected situation. However, there are formulas to basically get this coordination in place. In WHO we have emergency response framework. For the protracted emergencies, there is another framework that is under development. That framework defines exactly at what timeline of the emergency, what kind of the coordination mechanism should be in place, who is in charge, who should contribute. Of course, again, it doesn't mean that it is without challenge or any obstacles, but that will help a lot. And we've seen in the countries in the region that had already developed their emergency operations plan or emergency response frameworks, or those who had a functional public health emergency operations centers in the country, they were more successful in timely and effective response. Just in terms of the coordination, I want to mention sometimes during the pandemic, we faced the pandemic helped even for better coordination of the basically fragmented governance and the different powers in the same country. So basically, for instance, in a country like Libya or Yemen, so basically there were collaborations in terms of how to, as much as possible, coordinate the COVID response together. So basically, that's the best use of the emergency for under the Health for Peace agenda. Over to you.
Thank you, Ali. Alexis, you have just like a couple, probably half a minute for your answer. Would you like to share some with us? And then
well, in Peru, during the pandemic, we had 8 change of ministers, of which 3 were related to the tensions of the coordination with in the pandemic. However, the coordination with the regional and local level remain active due to the continuous work and the experience of the technical teams that continued in this issue in the pandemic problem. No? It's difficult to work with this change in the government, but finally the outcome were well successful.
Well, thank you, Alexis, and thank you all. Thank you, Jeffrey. Thank you, Julio. Thank you, Ali, and thank you for sharing. This will be closed as soon.
Okay. Okay, we have to leave then. Thank you very much. And we go to in the big room. Okay. See you in the big room.
In terms of talking about all the key points and highlights from all of the concurrent sessions. Julie? You are muted.
Hi, everyone. I'm Julie Pavlin, Director of the Board on Global Health at the National Academies. And I'm joined by Kavita Berger, who you just saw, the Director of Board on Life Sciences. And we both thank everyone for all your active participation in our 5 action groups. I know I'll be watching the videos of the sessions I wasn't able to be you live, and they will be up. All 5 will be up on the National Academy's website. The 2 that were live streamed right immediately after this, and the others, once we cut up all the, splice at the end and beginning and make sure they're nice and tight for you, they'll be up in the coming days for anyone who wants to watch what they've missed. We will be publishing a summary of our discussions that will be coming up in the next month or so. But for just a quick view, so you can see them now, we'll have all of our session leaders present the highlights of their group discussions. So please continue to use the Jamboard to add in your comments while we go through this. So first up is going to be Larry Brilliant and the Action Group on Situational Awareness in the Context of Health and Disease. So Larry?
Julie, we had a really sensational panel. I want to thank Kavita, who has taken such good notes, because nobody during that panel could have taken notes like this. So I'm referring back to them, Kavita. So I think the panel highlighted the importance of early disease detection and continuing surveillance and situational awareness as outbreaks emerge. We highlighted the inevitability of spillover from animals to humans, that human increase in population, cutting down rainforests, animals and humans living in each other's territory. I did quote Ian Lipkin, a figure that we published recently in Foreign Affairs, that there are an estimated 300,000 or more viruses in animals that have zoonotic potential in humans that have not yet been characterized. With this increasing pressure, there'll be an inevitability of new viruses jumping to humans, and outbreaks, therefore, are also inevitable. And then everything we talked about was how to sever that chain from the inevitable outbreaks to pandemics or epidemics. Mark Smolinski gave a really terrific overall presentation of how surveillance has evolved over the years, the importance of looking at an epidemic curve, which has in the past always been the joke among epidemiologists, that the epidemiologist arrives at the peak of an outbreak and rides to glory in the downhill curve. How do we move that peak 2 steps to the left, going beyond routine clinicians reporting, government reporting, sentinel reporting, moving all the way into digital disease surveillance systems, then after that into a One Health and participatory surveillance system. He really did an excellent job. And then we tried to highlight 2 countries, neighboring countries, Thailand and Cambodia, that while they are geographically neighbors, they're very different in their economic state of development. One has a high penetration of smartphones. The other has many analog phones, but not very many smartphones. And how they were able to develop homegrown surveillance systems, which are really the best in class worldwide. And what that did to the metric of evaluation, which is the time to detect outbreaks and the way that monitoring is done. And we learned a lot about the costs of these systems. The Cambodia system, 115, which is essentially an analog phone reporting system, cost about $1.2 million in philanthropic money to get started, and is now self-sustaining without government money, and will be able to endure the boom and bust of the epidemic. And likewise, the Thai system is now self-sustaining without additional funds. These are really illustrative for countries that were listening in on that conversation, how they can build their own surveillance systems that fit their unique geographic, cultural, and economic situations. And then we talked at the end of it, we asked all the panelists, what are their 1 or 2 most important lessons for everyone else? and they keyed on building community trust by having systems that gave back to the people who participate something of value for them, that allowed them to continue playing a voluntary reporting role. And what is of value to people sometimes is being included, being listened to, being responded. And that link between disease reporting and responding from the government or from the health system, that is the key to making these surveillance systems into a more situational awareness system that continues on. Overall, I thought it was a really terrific presentation, and I want to thank Mark Smolinski and Shanae and Kang for making it so lively, and all the questions that came in, and the National Academy for so artfully juggling all these different ways in which questions could come in. That was really a job well done. Thank you so much, everyone.
Thank you, Larry. I'll be watching your team later on today. So next, I would like to ask Richard Garfield to talk to us about what he has learned from his team on building trust, transparency, and risk communication capabilities.
So there was Larry with an aspect of trust, which was the bridge to what we did, trust and communications. We always say these are very rich sessions, but in fact, this one really was rich. It was kind of a rare opportunity that people who are engaged in this consulted with one another. So I think it was really quite enjoyable for us to talk and think together about these points. To come up with just a couple points from this is a very limiting charge, because there's a good deal of rich content here. And I'm only going to be able to scratch the surface of it in a focus that there was repeated discussion of the need to provide communications and a system of communications related activity that's continuous and not only appears when there is a crisis. If we are not prepared, if we don't have the means of having a dialogue with the communities of interest before the crisis, then it's on us to not blame the crisis for our lack of preparation. We now know that there needs to be a ongoing process of listening to key groups and communities and testing messages by having dialogue with them before we send out information. Part of the problems that we've been seeing repeatedly are the attitude that we have key information and it has to go out, it's urgent, and we don't have time to test things. There was very strong reinforcement that testing can be informal, interpersonal. Maybe it delays you by an hour, but it may save you weeks of correcting mistakes. And a very good point that came up in the discussion was the importance of both providing risk communication and then the health promotion information on what to do about it, but not to provide them in the same phrase or by the same actor, because it's very easy to misinterpret that as subjective activity or manipulation. Those who are providing the basic information on what the situation is ought not be the people who are suggesting what it is that we should be doing next. These are concurrent activities, but the importance of being legitimate actors means that they should be separate. There was very good thinking about how to deal with ambiguity and the importance of being honest and open. And again, kind of there was a sort of a spiritual underlying thing in our meeting here about how we don't have to make it complex to make it effective. That we do need to identify the communities of major interest or vulnerability. We do need to set up links with them, and that can't be just when we want them to do something. That this involves government and private sector. We had very good, useful content here from private sector in our session, business sector. And to identify who's vulnerable or who's missing from the conversation, so that those conversations occur before we ask them to do something. There's always time to have some dialogue. There's always time to listen back. There's always time to create, before an emergency, a context or a means of communication or a style or a format, a physical format, to provide information, so that people who are going to be receiving the information don't have to be identifying new approaches or new visualizations each day, that it can be progressive and building on stuff. That requires us to have some systems in place. And I'm reflecting now that pandemic fund applications are going in tomorrow, and that an awful lot of the applications that we've been working with countries are focused on equipment. Because that's some of the easiest stuff to fund internationally. But we're talking here about systems of discussion and engagement with communities that would be somewhat continuous. And I don't mean expensive and a large infrastructure, but I'm hoping that international agencies, which are the funders of most of these kind of things, will be brought to be more sensitive, and perhaps through this effort of ours here with the National Academy, to the need of the continuous operations of identifying key groups. I use the term market segmentation. Actually, the private sector people didn't go there, but that's part of what it is. And with a very logical approach to providing overall information of identifying what the situation is that we're dealing with here, anticipating how it may be impacting us or different groups, and then what needs to be adopted in order to minimize the impact or improve the results. And then I can identify with whom we need to be in communication, and which groups have not been at the table or have been disadvantaged and not listened to be sure that they're brought in. That is a brief attempt to kind of smush together an awful lot of good stuff, some of it having to do with structure, some of it having to do with approaches which are more effective in overcoming the ones that we have sometimes done, which we know to be less effective.
Thank you, Richard. A very, very stimulating conversation. And what we've learned in this pandemic is so important beyond anything is building that trust. So next, I'd like to ask Julie Wall to tell us about the conversation that she led on strengthening global health security through strong country-level infrastructure for effective governance, financing, and accountability. Thanks, Julie.
Thanks, Julie. We had a rich discussion as well on governance, financing, and accountability as it relates to preparedness at the country level. Regarding governance and accountability, kind of builds upon what Richard was just speaking about and engaging at the community level around these activities as well. And we discussed how there's a need for improved systematic approaches for accountability and communication and coordination with the private sector and communities, which is oftentimes lacking or acted upon as an afterthought, when in reality, engaging with the private sector and communities is an enabler for country level preparedness and should be better prioritized. We also discussed how preparedness capacities and capabilities can vary significantly even within a country, and accountability should not be considered only for technical implementation of activities, but also to ensure that legislation is in place that promotes equity and social protection in the event of an outbreak, as well as with outbreak prevention and detection. And we spoke about how important it is to have monitoring and evaluation systems in place at the national and subnational levels to ensure not only effective implementation of various preparedness activities, but also accountability among the actors who are engaged in these activities. And we also talked about how it was important to link these monitoring systems to maturity frameworks and key capacity measurement tools like the JEE and SPAR, so that outcome assessments can be routinely conducted and utilized for things like domestic financing advocacy. On the financing front, we talked a lot about how domestic financing and resources for health security remains a significant challenge, as most countries are still primarily donor-driven and largely under-resourced. And so unlocking domestic financing is essential as an enabler for improved investment in human resources. And we talked about how advocacy for this is essential. And tied to that, one of the main plugs, I guess, or takeaways from one of our panelists was that there's a need for increased country-led ownership of health security in order to unlock this domestic financing. And we heard from two of our colleagues, one from Ethiopia and one from Uganda, about how their countries have enabled a dedicated preparedness team or steering committee that's kind of responsible for this multi-sectoral coordination, governance, and accountability approach, but also works very directly with high levels of government to advocate for domestic financing and resources. And so that was a key recommendation as well, that countries enact some sort of steering committee and or dedicated team to ensure that there is a multi-sectoral approach that's well coordinated across the various public ministries, departments, and agencies, along with private sector and community organizations as well. And then we discussed how financial advocacy for preparedness is very difficult for a number of reasons, one of which how it's hard to quantify the return on investment for events that don't happen. So if preparedness is done well and effectively, then the outbreaks may not happen or may happen at a minimal scale. And so there was a call for academic institutions to quantify the return of investment of effective national preparedness efforts rather than just focusing on response. And I believe that is our key highlights. Thanks.
Thank you so much. It was a really very invigorating conversation. I was lucky to be able to listen into that one. Next, we're going to have our team that discuss the global health security capacity and functionality assessments, all those tools that were given to you. So Amr and Jessica, I'm not sure which one of you are our next one up to discuss that. Amr, thank you.
First,
both of you.
no, first Jessica, go ahead, then I'll be Jessica. Jessica, over to you first.
Oh, no, great. I huge thanks to our discussants, Anne, Magda, and Charles for giving really expertise input into this topic. And I'll just quickly note, one of the critical issues is that timely access to quality, actionable data underpins effective prioritization of investments, right? So this is really a lot of sort of the cornerstone of what we're talking about in this symposia. And we really asked our discussants and the group to kind of look at three overarching sort of topics, which is really, one was identify the challenges in the use of existing tools, and how to improve that, how to address that. Identify opportunities to improve the interoperability and interconnectedness and integration of assessment tools and their data. And the third section was identify opportunities to improve linkages between capacity, capability, guidance, and sort of the tools. So how do you then operationalize? And are there challenges? Are there opportunities to improve that? I'm happy to touch on a couple things, which one was, I think, as we've heard a number of times, there's a difference between sort of the capability assessments and the functionality, and that both are absolutely critical as we go forward. One of the themes that was raised was about the critical need as it relates to engaging local. And this is, making sure that the tools are accessible locally. And one of the key issues that was raised was oftentimes the language barrier, but also potentially the burden of having multiple tools that cover the same issues, and also the lack of sort of feedback. Okay, the data maybe doesn't go anywhere. What is the utility of the data that's there, and some of the sort of potentially siloed nature of, when you have those sort of assessments. So a look to really making both the tools more accessible and reducing the overall burden that's placed as it empowers sort of local use of the tools, the data, and then the next steps. Another key theme was promoting partnerships. And this was across diverse sectors, but also being mindful of the ecosystem, that it's not necessarily just health, but, kind of that broader ecosystem when you're really talking about assessing capability. And then one of the issues was a great discussion on, as we're relating to trying to address the gaps is focused on, demonstrating examples of successes and having exemplars, and that we need to be able to empower not just the assessment, but really empower the steps that are taken after, and the role of not just the guidance, but also these exemplars and empowering that sort of lessons learned in community. So I'm going to hand over to Amer now. Thank you.
Thank you so much, Jessica. And definitely, we had a very productive discussion. And this may be the beginning, I'm sure, of much more to come. I think there have been some few things I've already pointed out, that the language barrier, but I personally feel that definitely there are so many tools, and there is a scarcity of training in those tools. So how to cover up that? I mean, if the tool is from WHO and FO, to whose responsibilities, and then combining those tools and making them much more simpler, easier. And as we go through the Jamboard as well, such suggestions coming up in simplifying the things and communication. I think communication is one of the key strategies that has come up overall during this great symposium. I would like to extend my deepest gratitude to National Academies of Sciences, because what I personally feel, this is the right time. We are coming out of a great crisis, and we have the richest possible experience in hands. So we need to put that on paper. We need to put them and strategize for the future, and not only strategize, make it implementable and make it implementable globally. I mean, we have to take along the countries in that regard. You see, the time has come. We are talking of the pandemic treaty. The time is there when the World Bank has already come with financial resources, and Richard has already pointed it out. And I think, getting the equipment is the easiest task, but the sustenance and the sustenance model here again, I think, comes the role of bodies like National to guide them for the future. That sustenance is the job of the government. And from here on, this is a huge funding coming for the future pandemic preparedness and how to take it on. And not only that, this funding can in turn be utilized for understanding of the available tools within the country, within the region, and globally. And definitely not only implementing them, but I think in making the interoperability possible. Now, this is again an area where there are so many systems working in silos, not within the countries, but definitely globally as well. And this definitely difference we did feel a lot during the COVID crisis, I think. So we need to learn from that experience, bring it back on the table, put it all together, strategize it in a way that all the countries, the regions, and then at the global level, things become much more simpler. In the discussion, we've been talking of unstructured data, local versus the global data, and how they're talking to each other. And I think the exemplars, as already pointed out, with the whole of the government approach, the public-private sector, putting in effort together, and then definitely the role of the primary healthcare. I think this is yet another area which has been pointed out, and I personally feel in the developing countries, this is again, we need to concentrate on the primary healthcare. So once we talk of the universal healthcare, this is the main strategy that needs to be focused. So there's much to learn, much coming together at the time. And I'm sure with all the experience of the experts overall joining the symposium and the audience, having had participating in multiple activities during the COVID crisis, we need to put our hands and strategies together to make it much more safer and healthier world. So once again, thankful to the panelists, thankful to Jessica, and thankful to the National Academies for the wonderful job that they have initiated. And I'm sure they'll take it along in a very methodical manner. Back to you. Thank you.
Thank you so much, Amar and Jessica. Great words there. And finally, our experiences, the countries and organizations' experiences that they have had in preparedness and response planning. So I'm not sure, so I'll pack Erwin or Arminder, who will be kicking us off here. Looks like it's Erwin.
Yeah, thank you. Well, first of all, I think it's so important to recognize the great work of those that were with us today. Thank you so much to the National Academies, and thank you so much to the committee members for all the effort for today. And I want to thank especially for the participants who made this a wonderful experience for us. So in our action group, which was this countries and organizations experiencing preparedness and response planning, we had the goal to identify lessons and best practices for preparedness and response at national level and identify action and policy and practice for improving preparedness and planning for the next pandemic by learning from what went well and what went wrong at national levels. And we heard from our wonderful panelists, that is Alexis Holling from Peru, Jeffrey Carter from Singapore, Ali Arlan from WHO, Julio Crota from Brazil, who were amazingly substantial in what they shared with us based on the best experience, how you put together 3 years and how you put together what has happened after those 3 years, so that we can share with all of you what at the end should be the takeaway from this meeting. So I will say we found out probably 5 key issues in here. I think if one is, someone has opened its mic. Sorry for that. First of all, we have a big concern about addressing inaccurate and misleading information about biological threats. That basically comes out from other discussions that were devised and developed by my peers, Richard, here in the committee. And that's still an issue that is very important in regards to prepare. The other aspect has to be, the second point was, before COVID-19, there were already networks that were key for the response. So we have the experience from the Asian in Singapore and the Zika infrastructure in Brazil. And we also heard from Peru. And there are certain specific contexts that needs to be taken into account, because the dynamic globally, since that was the basic aspect of this pandemic of SARS-CoV-2, it took over the entire globe, and the entire globe in each region and each country has a specific context that needs to be taken care of taken in as part of the analysis to be able to move forward in the response. The third point was the external assessments are useful, but will be useful as long as governments use it. And that's something very important. So science, government, and COVID-19 was a very political, the political pandemic, very complex from the epidemiological perspective and public health perspective. It raised up many political situations, or it developed in very complex political situations. When it was key, and will be always be key, the communication between those that take care from the public health and those that have to make decisions and make policies and do the final decisions for the well-being of all human beings. Then the fourth point was the increased number of laboratory capabilities after the pandemic has been a key issue. And this also was analyzed by Laurie's group. So how important is that infrastructure that now exists that we can use to be better prepared for what has happened? We saw a little bit of that with Mpox and how fast we can respond and how we can use all the human resources and leverage with what we already have with equipment to be able to respond to the next pandemic. And fifth will be, I think, something that was very interesting personally to learn out of this action group. So the future in preparedness for the next pandemic, it will not only be from what we will see as a pathogen. We're talking about that the world needs to prepare for something more integral, vast, which will be for problems like climate change, taking into account that we need to have the One Health approach in mind, and that there are other health emergencies in conflict areas, and looks like that will be the vision, at least from some regions, and that be some of the takeaway, not only thinking about a pathogen, but the more meaningful aspects that put into risk humanity instead. And that's very rich fifth takeaway from this. So I express my gratitude and hope these 5 points of view that try to summarize the rich experience of our panelists. And again, thank you to Suapak and Armina for being able to moderate this so kindly with us in this action group. That will be the basic points that I wanted to share.
Thank you so much, Erwin. And now I'd like to turn things over to Kavita to lead our discussion. For those in the Zoom room, please raise your hands or enter any questions into the chat. And I still keep entering things as you can into the Jamboards, and I think Slido link is still available, so we can use that as well. So thank you, and on to you, Kavita.
Thank you all so much. So we have about 15 minutes. I want to give you all an opportunity to share additional sort of lingering thoughts, actions, suggestions, as you reflect on the day's discussions and the readouts from all of our concurrent action groups. And as you're thinking, I want to share a few sort of common things that we heard either on the Jamboards or in the conversations as well that might be useful to bring about. So one of them, in the risk communication, the importance of honesty and the messenger who is delivering that message. I think Richard mentioned this a little bit, but it's useful to point out because several of the Jamboard sticky notes had mentioned that as well. And in the chat, Rania had mentioned having a people-centered, community-led partnership engagement as a way of helping to build trust, transparency, and good risk communication. In terms of both the financing and the preparedness, what was interesting is that the issue of social media and fake news shared through social media and the challenges that presents to both preparation and response was highlighted. In both cases, it looks like there was some discussion about needing to have some means of getting ahead of that before we continue to see, all of the challenges persist and apply to other epidemics and pandemics. In the assessments action group and preparedness, we heard common issues of data standards and the need for data standards and issues of data sharing within countries, across countries. So obviously a very big issue here. And just want to reinforce one thing that seems to have been common in both of those as well, which is that assessments are useful, but only if they result in action. And a question that remains is, what are the hurdles that prevent action? Is it government commitment? Is it the ability to have long-term financing? Are there other things that are contributing to this? And I know we talked, at least in the preparedness group, about a number of different issues there. And then something that seemed to be throughout all of the action groups is communication and the need for strong communication throughout and building of trust throughout. Not just in a crisis moment, but when we're in between large epidemics, that it's not something that should necessarily be only done in an epidemic or a pandemic. We did have one question online, which I want to share with all of you, which is whether anybody had talked about spillover from habitat destruction and land use. And I will say in the preparedness action group, we did have a little bit of conversation about that, but it was, and I think we also had a conversation about that in the surveillance group, the situational awareness group this morning as well. But that, that in addition to climate, changing climate and other climate issues, to conflicts, to displacement of people, all contribute to what's going on in the background here. So I will stop speaking. As you can tell, my voice is not doing so great. And want to turn it over to anybody else who would like to actually say anything or respond with their own thoughts and actions. I see few people have unmuted. Larry, go ahead, please.
Yeah, I think the background of where we are is important, and as we put all these things together, the context. About 8 years ago, Warren Buffett, who's this legendary investor, the guru of Omaha, who was the major financer of the reinsurance industries around the world. And reinsurance is really important because you can't have an insurance policy against a disaster of any kind unless there's somebody who's going to, put all those insurance policies together and create a reinsurance portfolio. Warren Buffett decided he was going to leave the entire field of reinsurance because he felt he was incapable of quantifying what the damages would be from a pandemic. It puts pandemic in a very different risk position than earthquakes and hurricanes and other catastrophic events that are more localized. There once was a time that in the United States, we would talk about some of these disasters like floods, and we would call them once in 100-year floods or once in 500-year floods. Implicit in that idea is that if you've had that flood this year, you don't have to worry for another 100 years. So let's put these two things together, that the risk of a pandemic, the costs of a pandemic are incalculable by one of the greatest economic minds of our lifetimes. And that the appearance of the COVID pandemic may give people the feeling that this once in 100-year event has happened and you can lay down stop worrying for a little while. Well, that's not true. All of those things which increase the risk of a pandemic are accelerating. Climate change, human population, animals and humans living in each other's territory, more consumption of meat, more consumption of wild animals, rainforest clearing and changes in habitat. Those things are accelerating. The risks are incalculable and they are increasing, and we are letting down our guard. And that's the moment that we're in. And that's why it's so important what the National Academy has just done to bring us together to have this conversation. But I don't want us to lose the preface, to lose the forward to the book, to lose the context.
Thank you. Marty.
Yeah, as often is the case, Larry and I are thinking along similar lines, and I just want to take one next step to his concept of outlining the context. These things are increasing in frequency, they're increasing in duration for each event, and they're increasing in magnitude and geoscope and speed. So that really does highlight the challenge. But I think that because of that, and we refer to a lot of these things as syndemics, which birth and potentiate the problems that we have, these syndemics. I think the challenge, though, is we haven't yet adapted a model of pandemic preparedness or readiness or response that takes this context into account. We are still thinking about pandemics from a pathogen perspective. Sometimes we think about hosts from an equity perspective. We don't actually fully incorporate milieu, the third leg of this critical stool, which is the social context in which all this is occurring. And that's political milieu, violence, displacement, et cetera. We don't have yet the integrated system of articulating when we're thinking about how we measure the pandemic. And I've seen this a little bit in the Berlin Hub presentation early in the first session. How do we actually integrate our data model so that we're not thinking about cases, hospitalizations, and deaths, but we're also thinking about how are all those things interacting with economic stability, interacting with mental health, interacting with equity, interacting with the political, how that affects the political dialogue or the debate around democracy and autocracies, which clearly emerge in this setting of fear. We need a more integrated set of measurements. We need a better way to measure, evaluate readiness and preparedness that the JEE has really failed us on. It's been extremely unidimensional, and yet the complexity of the problem we're facing is clearly multidimensional. And so we have to have all of those. We don't have to not only have the sectors present, but we have to have the tools and the metrics and the feedback loops as we go along, often with uncertainty at a pace that's faster than our systems are ready. We have to have a data model and a visualization model and an impact model and an OODA loop, observe, orient, decide, and act. And we have to have those things built into our structures of pandemic readiness, response, and preparedness. And I think unless and until we do that, we're still going to fall short of the challenge that everyone has been articulating in these meetings.
Thank you so much. I want to invite anybody else who would like to comment, but I do want to stress one thing that you had mentioned, which you're right, came out in the first discussion on situational awareness, which is looking at it at a system and from a systems lens, and looking at all of the different data points, not just public health data points or scientific data points, but even, other things that are happening, and how that informs not just the causal relationships between all of these different things that are happening, but the downstream effects. It's quite a large scope, quite a large challenge, and but that sort of complex system of systems in which we live just is highlighted every time we do a retroactive analysis on any type of epidemic and pandemic. Well, thank you all so much for sharing your thoughts. Again, as Julie mentioned, please feel free to share your additional thoughts on the Jamboard. We will leave it open for the next several weeks. We're going to turn it over to Lisa to give our closing remarks. But I do want to mention to you all that the information that we have discussed here, we will actually be producing in a proceedings in brief for everybody to have access to, including the information that is on the Slido and the Jamboard. So Lisa, please.
Thank you. And how to close out this amazing 4 hours or so of rich content. I think this is our second symposium session. It has such rich technical content, but also you can see an underlying theme of a desire to do better for future epidemics and pandemics. And each one of you has not only worked tirelessly during the most recent pandemic, but also has this innate desire to make sure that we do things better for future. We have learned lessons from countries that can be scaled and how they've successfully established preparedness and response mechanisms. And the conversations today have really stressed how we need to examine history, how we have to look at timelines and surveillance, and how we have to be forward thinking for the global health security of our world's future. And I thank very much the National Academy for hosting this incredible symposium, day 2, because it gets us to that point. It's actionable, it's forward thinking, and recognizing what do we really need to make changes and adapt. We've heard several themes emerge. Many of them have been stressed, but a couple I'll just stress again is the systems strengthening approach, and whether it be our disease detection and situational awareness, our data quality, measurement, communications, all have to be strengthened, and they have to be resourced at all levels. And we've heard about financing and country financing, which can be difficult, but there has to be advocacy for this, whether it be at all levels of preparedness, including the communications piece, which is often underfunded. We've heard again and again about government and country-owned and multi-stakeholder engagement with countries, including the private sector, including academia, like events like this, and involving populations that are affected, but are also most underserved. We've heard about the equity piece, about representation, and translating policy and action and accountability mechanisms to ensure that equity and social protection actually exist. And those approaches are built into our preparedness and response plans. And finally, on our tools, our training, our capabilities, Again, it goes to country-led accessibility, simple language, and better measurements tools that are accessible and easy to use for countries and regional level. I'd like to thank you again for all your time. We do have one more session on June 9th from 9 to 10:30 a.m. Eastern Standard Time. And this will identify additional gaps and the action forward and characterize these opportunities and challenges that either enable or limit our achievement. Please join us for that final session. There'll be an opportunity to reflect on the action discussed on May 4th and today, and highlight these key near-term and long-term actions and associated actors, which hopefully will include most of you. Thank you for your participation today. And as a reminder, we're posting these recordings of the sessions in the next few months, and they will be available on the National Academy's website. Thank you for your meaningful participation, and a very big thanks to the National Academy's team for organizing such an important event that took in multi-stakeholders from academia, country level, WHO, implementers, so many, and the technical planning committee for all of your thought leadership and your expertise and your time investment. We look forward to seeing you on June 9th to contribute to the action-oriented dialogue. Thank you very much and have a good evening, afternoon, and the rest of the day.